Tes. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi kepada yang saya hormati para pembicara dan moderator yang telah hadir, Kepala Departemen Mata, seluruh staf Departemen Mata FKW RSCM, dan seluruh dokter spesialis mata, serta seluruh residen di Indonesia. Also, we would like to welcome our honorable speakers from National University Hospital Singapore, Dr. Yuan Yusan and Dr. Daun Lim Kaan. Also, we welcome our attendees from Singapore and other countries. Selamat bergabung pada seri ketiga dari rangkaian RSCM Kirana-NUH Collaborative Webinar Series. Sesi ilmiah pada hari ini mengenai retina, uveitis, dan malignansi pada segmen posterior. Ladies and gentlemen, we'll begin our webinar. Hadirin sekalian, acara webinar ini akan dimoderatori oleh Dr. Gita Lisa Andayani, spesialis mata konsultan. Kepada Dr. Gita Lisa, spesialis mata konsultan, saya persilahkan untuk memandu acara selanjutnya.
Hi, Linda. Can you see my slides now?
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi saya ucapkan pada seluruh teman sejawat yang sudah bergabung pagi ini pada the third collaborative webinar series yang organized by RSCM Kirana dan National University Hospital Singapore. Good morning and welcome to all of you who have joined through Zoom and also through a YouTube channel, and a special welcome to our speakers from Singapore, Dr. Daun Lim Kaan and Dr. Yuan Yusan. It's an honor for me, Dr. Gita Lisa Andayani, to be your moderator for both our sessions today. We'll have two very interesting sessions today, both focusing on various pathologies of the posterior segment. And after the talks, we will have question and answer or discussions, and you could write down your questions on the Zoom chat or YouTube comments. So we will start our first session, which will feature three important talks from three distinguished experts in their fields. Let me introduce you to the first speaker from Singapore, Dr. Daun Lim Kaan. Dr. Lim is a consultant at the Ophthalmology Department of National University Hospital Singapore and currently the head of uveitis service. She had her training at Moorfields Eye Hospital UK, and is also Assistant Professor of Yong Lu Lin Medical School, National University of Singapore. Dr. Lim will talk about a topic that is always a challenge for us practicing ophthalmologists, both in diagnosing and treating, which is the many phases of uveitis. So please, Dr. Lim, the screen is yours. Dr. Lim, you may
Yes.
share your screen.
Okay, thank you. Can you see my slides? Can you see my slides then?
Yes,
Yes?
please.
Yes, okay. So a very good morning to everyone. I'm Dr. Donlin from Singapore. Allow me to take the first opportunity to thank Dr. Tria and the organizing committee for the invitation to share my talk entitled The Many Faces of Uveitis. I have no relevant financial disclosures. Now, one of my favorite book characters is Sherlock Holmes, and the author, Sir Arthur Conan Doyle, was reportedly an ophthalmologist. So I guess if he had a choice of subspecialty in his time, he might have made a very fine uveitis specialist. Taking a quote from his book, "Now the skillful workman is very careful indeed as to what he takes into his brain attic. He will have nothing but the tools which may help him in doing his work. But of these he has a large assortment, and all in the most perfect order." And this very much describes the work of a uveitis subspecialist. Uveitis is an evolving field with the exciting advent of new tools such as wide field imaging, which has availed itself in the form of optos, photos, ultra wide field retinal imaging as well, and OCT angiogram. However, notwithstanding the excitement around the new technology, the basic tenets of uveitis practice remains unchanged. So allow me to share with you 4 pearls in uveitis management this morning. But before that, here's another quote from Sherlock Holmes. "When you have eliminated the impossible, whatever remains, however improbable, must be the truth." Quite a handful of tongue-twisting words, but the key really is you, or us, as the reviewing ophthalmologists, as we sieve out the necessary information in problem solving in uveitis. And with that, let's begin with the first pearl. Listen to the patient. This enables us to determine the primary site of inflammation and hence direct our history examination workup and treatment considerations. The SAN work group, representing the standard uveitis nomenclature work group, divides the primary site of inflammation, or rather it classifies it into the anterior chamber, anatomically into vitreous, retina, choroid, or all sites. And this uveitis involving the anterior chamber would be termed anterior uveitis, vitreous, intermediate uveitis, retina, choroid, posterior uveitis, and all sites being panuveitis. Patients with anterior uveitis complain of pain, redness, photophobia, and those presenting with floaters and blurring of vision, you might think that this group of patients would possibly have intermediate or posterior uveitis. With pain on ocular movement, you might consider posterior scleritis or orbital inflammatory disease. And Vogt-Koyanagi-Harada disease or sympathetic ophthalmic patients normally present with just blurring of vision. So let me commence with the first example of this 27-year-old male patient with bilateral red eyes, photophobia, with slight blurring of vision of 2 weeks duration. And then he tells you at the same time of simultaneous onset with the red eyes, his back started hurting whenever he lies down. So if we heard the patient, got him to raise his shirt, examine his back, you would have noticed that he has this red induration, erythematous, tender to touch tattoo on his back. He was co-managed with a dermatologist who promptly did a skin biopsy, and that showed up as non-caseating granulomas. His serum angiotensin converting enzyme returned elevated. Lung scans, brain scans, liver function test was normal. And there we have the diagnosis of sarcoidosis. And the photo in the bottom right shows him 2 weeks after the commencement of systemic steroids. So next thing is that listening to the patient allows us to ask the relevant questions in regards to pertaining history for systemic problems or any other associated diseases. So relevant questions would be a history of ocular trauma, surgery, if you're thinking about sympathetic ophthalmia, or perhaps in a patient with a hypopyon fibrin uveitis in a young man, you might inquire about back pain or known history of spondyloarthropathies, or someone in whom presents with panuveitis, you might want to inquire further about the immunocompromised status. You might want to inquire about family history of systemic inflammatory disorders and take a drug history where relevant. Now, the next example to demonstrate the first poll will be this 67-year-old lady who is on long-standing follow-up with the clinic for primary open-angle glaucoma on taflotan. The right eye pressures on her routine review was 18, and now we start noticing that the left eye pressures have crept up to 24. And on further examination of the anterior segment in the left eye, start seeing the fine, small, stellate-looking KPs. And she tells you that she has cancer of the ovary and is currently in remission for the past 1 year. So one might gather or ponder whether this might be CMV anterior uveitis. And the only test we did for her was the aqueous test, which returned positive for CMV DNA, and she was promptly treated. Pearl number 2, look at the patient and not just the eyes. So our next case is a 35-year-old lady who presents with a left eye blurring of vision, floaters of 2 weeks duration. In her anterior segment examination, you have noticed the broad-based posterior synechiae. And now you understand why she's complaining of floaters more in the left eye, because there's a little bit more vitritis of about 1+ in left eye with vitreous snowballs, again, better appreciated in left eye, but some small vitreous snowballs in the right eye as well. And you notice that she's unusually cachectic. So you ask her more questions, and now she tells you that she has an unintentional weight loss of 10 kilograms over 1 year, no previously established medical history, but she complains at the same time of a right hip pain, no cough, hemoptysis, but there was a positive tuberculosis contact during her childhood with her father. She was co-managed with the infectious disease team and the rheumatologists. Several scans were done for her, and the scan on the left shows the MRI of the spine, T2 weighted image showing a bony destruction of the S1 vertebrae, multiple levels of lymphadenopathy extending from the supraclavicular in the picture on the right top, in the middle picture, pararenal lymphadenopathy, pelvic lymphadenopathy, and the bottom picture showing a paraspinal abscess. She was actually referred on to the radiological team for radio-guided aspiration, and the aspirate was sent for cultures that returned positive for Mycobacterium fortuitum. T-spot TB, TB quantiferon returned positive, retroviral test was negative, diagnosis is that of disseminated TB, which is comments on TB treatment. Rule number 3, there is no standard or general workup in uveitis. So I always tell my residents, basically there is no routine, there is no standard, there's no general workup in uveitis. We have to decide what investigations to do based on the patient's history and examination. So Dr. Watson works closely in crime solving with Sherlock Holmes as a sidekick, and is most impressed with Sherlock Holmes' proficiency in observation, deduction, forensic science, logical reasoning that borders on the fantastic. And as he exclaims here in this quote, when I hear you give your reasons, I remarked, the thing always appears to me to be so simple that I could easily do it myself. though at each successive instance of your reasoning, I am baffled until you explain the process. And yet, I believe that my eyes are as good as yours. So the key advantage here is that what Sherlock Holmes enjoyed wasn't more information than anyone else. It was the ability to see that information differently, or perhaps to direct his search for information in a systematic manner. And this is the very definition of problem solving in uveitis, the ability to see significant connections and patterns. So let's go on to the next example. A 31-year-old male, red eye photophobia. You would have think that this is a HLA-B27 type anterior uveitis, isn't it? So would you send off an anti-nuclear antibody screen? The answer here would be no. Conversely, you have a 52-year-old female, red eye, incidentally noted by oncologists, previously known to the eye clinic for recurrent episodes of HLA-B27-like anterior uveitis, cataract surgery done more than 10 years ago. So you notice this is in an anterior chamber. She has a dislodged, the green arrows point to the dislodged fibrin clot that was in front of the pupil, but post-dilation that has actually fallen inferiorly. There's also a level of hypopia inferiorly as well. Would you think that this might be a recurrence? Possibly. Would you send off an anti-nuclear antibody screen? I would say no. And then she offers, or she tells you, or you notice in history that she has metastatic breast cancer with a chest wall mass, and she's diabetic. Now we start entertaining the possible differentials of an infective cause or a masquerade, like tumor metastasis. This was her retina for her fundus photo, Optos fundus photo, that shows that basically does not show any evidence of posterior inflammation. And so we gave her a short course. We gave her started her gingerly on a short course of topical steroids, to which she responded, and basically the anterior uveitis resolved. So in the considerations of differentials for uveitis, one must always first exclude or entertain the possibility of an infective cause. The IUSG, or International Uveitis Study Group, has a clinical classification for etiologies, and it classified that into infectious etiologies, non-infectious or autoimmune causes, and masquerade causes, which includes neoplastic caused etiologies such as lymphoma and leukemia. Let's move on to the next example. It's the same for anterior segment photo of the same patient. You notice medium to large mutton fat KPs, carotid precipitates, and there is corneal edema as well. What do you think? One might ponder if this is a HSV or a hepatic-like anterior uveitis. Would you send off an A&E screen? The answer again here is no. A 32-year-old female, vision 6-6 recurrent uveitis, intraocular pressures of more than 30 with each episode. You notice an area at 4 o'clock, an area of sectoral iris atrophy. Would you send off an A&E screen? Again, no, because we should be possibly considering the likelihood of a zoster anterior uveitis. Allow me to share this slide entitled A Fisherman's Guide to the Workup in Uveitis. Bring your fishing rod when you look for uveitis. You really have to fish for the possible causes. If you cast your line, you have to reel it in. That is, if you do a lab test, you have to follow up on it. And don't fish for things one does not know how to cook. And as Dr. Van Gelder shares, that uveitis cases are rarely associated with systemic lupus erythematosus, or SLE in short. And oftentimes oftentimes when an A&E test comes back positive, we're pretty much stuck, isn't it? Now with a positive lab test that needs to be followed up and referred on to a rheumatologist when the patient probably doesn't have lupus, because up to 30% of the healthy population can have this antibody in their serum. And also a viral infection can give one a false positive result for A&E test. So I don't pretty much order this in my practice. The fourth pro, there is no standard management. And a classic example of this is in the management of raised intraocular pressures in uveitis. This can be broadly classified into secondary ocular hypertension when there is no visual field defects, or secondary glaucoma when there are visual field defects seen. We'll go on to the causes later, but allow me to share with you an example here first. With a 32-year-old male presenting with sacclusal pupillae, notice a fibrin plug in the center of the eye in front of the pupil. And if you lower the lid, you have noticed a sliver of hypopyon, iris bombay of 360 degrees with a shallow peripheral anterior chamber, intraocular pressures of 56 in the left eye. So what would you do next? The pressures remain 55 on maximal medical treatment, including oral dimoxamethasone. Would you do a laser peripheral iridotomy? The answer here should be no. Instead, you should be given 1% tropicamide, 10% phenylephrine, one being sympathomimetic, the other being anticholinergic. So they work synergistically to dilate and break the posterior synechiae, and you see how his intraocular pressures improve subsequently from 56, 23, and an hour later to 11. So in management of raised intraocular pressures in glaucoma, we must consider the pathophysiology. The ocular inflammation leads to the breakdown of blood aqueous barrier and hence the liberation of protein and inflammatory cells into the aqueous, which leads to the formation of posterior synechiae and sometimes choroidal or ciliary body swelling in certain pathologies that might result in secondary angle closure. The mechanisms can be broadly classified into secondary open-angle glaucoma, ocular hypertension, or secondary angle closure with or without pupil block. The last example is that of a 54-year-old male, right eye phthisis, left eye having gone previous cataract surgery and cryotherapy for retinal tears. He presented with left eye pain and blurring of vision of 1 day's duration. On examination, he was found to have sluggishly reactive pupils. The pressure was 55 millimeters mercury at presentation, improving to 38 later, an hour following DIMOX. Cornea was hazy from the raised intraocular pressures. It's noticed that his anterior chamber was shallow. There was very limited view of other details in the anterior chamber and the posterior segment, given the corneal haze. So he was referred on to the uveitis service after laser peripheral iridotomy and yet hyaloidotomy, presumably to treat pupil block and aqueous misdirection. And by then, his vision had deteriorated to count fingers, intraocular pressures hovered above 40, and was uncovered from the inter-hospital records that the patient had previous history of being managed for sympathetic ophthalmia in another hospital. This shows the anterior segment photo, anterior segment OCT of the left eye, pre-laser iridotomy above, and the ultrasound biomicroscopy picture of the same eye post-laser peripheral iridotomy. If you observe closely, the angle structures or morphologies in the anterior chamber depth has not changed a single bit post-iridotomy and yet hyaloidotomy. The pressures still remain high and vision still remains at count fingers in the left only seeing eye. This was a fundus view of the sunset glow in the left eye. And this is now how the eye looks post-intravenous methylprednisolone with deepening of the angles. If you compare that to the pre-IVMP picture in the right upper corner, his anterior chamber depth has significantly increased with widening of the angles as well, and his vision has improved from count fingers to 618, and pressures are a little bit more acceptable now, 26 on eye drops. Again, this is another slide showing the UBM, the ultrasound biomicroscopy images, the same sections of the eye pre and post intravenous methylprednisolone, where the angles have widened in the right picture. He subsequently, because of the dependence on oral and systemic acetazolamide and maximal eye drops, we proceeded to implant a glaucoma drainage device, did a posterior synechialysis and iridectomy for this patient. And this is him post-operatively. If you notice, at the 1 o'clock, you do notice a tube in the anterior chamber. His vision improved to 612. Intraocular pressures was 9 millimeters mercury off all medications for glaucoma. This shows the sunset glow rate reflex. And again, anterior segment OCT, showing how the anterior chamber depth has further widened at angles as well, post-surgical intervention. So in summary, in uveitis practice, we have to listen to the patient, look at the patient, remember that there is no standard routine or general workup, and there is no standard management. I'd like to acknowledge the following colleagues who have contributed in part to the images and photos used in today's talk, and thank you for your attention.
Thank you very much, Dr. Lim, for your excellent talk, which provides us with useful pearls for our clinical practice, especially when facing patients with uveitis. We will have some questions at the Q&A session right after all the speakers have presented their talks. Again, we invite the audience to please write down your question in the Zoom chat or YouTube section comment. So let us move forward with our next speaker. My colleague from RSCM Kirana, Dr. Rina Ladistianora. She is our infection and immunology consultant of the Department of Ophthalmology, RSCM Kirana, Faculty of Medicine, Universitas Indonesia. She earned her PhD degree from Erasmus Medical College, the Netherlands. And she is also active as a various committee member in the Indonesian Ophthalmology Association, or PERDAMI, and also the Indonesian Infection and Immunology Society, or INOIS, and also as committee member in Future Donor and Recipient Management of the Indonesian Eye Bank. So I think without further ado, I welcome Dr. Rina Ladistianora to present her talk. Please.
Thank you, Dr. Gita Lisa. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. So today I would like to talk about tubercular uveitis and why I talk about this morning, because this is what I have passion about, especially when we spot problems in Indonesia. Actually, TB uveitis is quite prevalent in Indonesia, but sometimes we are not sure whether to give ATT or obat anti-tuberculosis or not. So we did a prospective study in 2014 and 2015 in all new consecutive uveitis patients, and we found that infectious uveitis is most prevalent known uveitis in Indonesia. As you know, like what Dr. Don has said, uveitis is the umbrella of more than 30 kind of disease, different kind of disease. You have to be a Sherlock Holmes to find out what it is. And we found that most of our uveitis are infectious. The first cause is toxoplasmosis. We have 19% of toxoplasmosis. And the second cause is a patient that was associated with active pulmonary TB. But when we did PCR from intraocular fluid, it's rarely positive for TB. And most of our patients, 66% of them, came with less than finger counting. So sometimes it is hard for us to identify the pathognomonic clinical signs. So it's kind of difficult to become a Sherlock Holmes in Indonesia. So then we did testing. We checked for the IGRA and TST, or Mantoux test. And we found that even in healthy control, we have 29% positivity. But in our uveitis cohort, we have found 66% of them are positive for IGRA, and 8% of them, they have active TB in their lungs. So we collaborate with our internal medicine doctors, and for them, it's not difficult. We can just give them the anti-tuberculosis. And then 18% of those patients have other established cause of uveitis, so we don't treat them with ATT. But then we have 40% patients that we could not figure out what is the cause of the uveitis, and they have MANTU positives. So in this population, it's hard to decide whether to treat with ATT. And you know, when we decide to give ATT, it is a multi-drugs medication. We have to give it for 6 until 9 months. And we know that it is really toxic to the liver. So there's a consensus, there's a guidelines from Dr. Gupta in 2015. So we divide the ocular TB into the confirmed or probable or possible. It is based on whether there's a suggestive clinical signs, and it is confirmed if we found the MTB in the ocular tissue. But it is probable or possible depends on whether we found the MTB other than the ocular tissue, and whether the chest radiography is consistent with TB infection, yes or no. Besides these ancillary testing, we also look for the possibility of TB exposure, so history of contacting with other active TB patient, and immunological evidence from the MANTU test or the TST test. So it is probable if we found the MTB somewhere else, and or the chest radiography is characteristic for active infection. And it is possible if we could not find the MTB somewhere else, or we found it, but the MANTU test or the TST test is negative. And the most important thing of all is we have to exclude other etiologies before we can decide it is it is a TB. The problem is it is hard to confirm the presence of MTB in ocular tissue. Why? This is a very good study by the team of Prof. Narsing Rao. They check for the last 75 years of all histopathological samples from the eye, and they look which from them are having MTB in their eyes. And they found in those 75 years, they found 42 patients that have TB, and it is paucibacillary, which means there's only 1 or 2 MTB, and it is located in the RPE cell layer, so it's really in the back of the eye, and it's already causing severe inflammation. While among those patients that have available MANTU data or chest X-ray, there's only 60% of them TST positive, and only 43% of them have chest X-ray that is abnormal. So it's kind of hard to have a hint from the ancillary testing. And the MTB could not be positive from only PCR from the aqueous tab. So with all those difficulties, so how do we approach TB uveitis? So first, I think we should know the predictive clinical signs, and we choose diagnostic tests wisely. And afterwards, we have to look for the treatment response. So what are the clinical signs? This is a good study by Dr. Gupta about the ocular signs that is predictive for tubercular uveitis. They have a high prevalence case, and they found that the broad-based posterior synechiae, vasculitis with or without choroiditis in the retina, and sepiginous-like choroiditis is really predictive, telling us that this is most likely a tubercular uveitis. This is an example of the picture of broad-based posterior synechiae that can hint us it is a TB, and this is the opposite, the filiform posterior synechiae that have least predictive for TB uveitis. And then that is for the prevalent country or endemic country. What about the non-endemic country? So I did also a retrospective study in a non-endemic country in the Netherlands, and we had a multi-center study. So I took samples and data from 3 separate centers and looked at their medical records. From all those 3 years, we only found 96% patient with unknown cause and quantiferon positive, and which we finally include 77 patients. So you can compare the prevalence between India and the Netherlands. For all 3 years, we only can find 77 patients. And we found that the clinical manifestation that is probably hinting us it is a TB is almost the same, serpiginoid chorioretinitis. So it's serpiginous-like choroiditis, anterior uveitis, and occlusive retinal vasculitis. So we can see from the endemic world and the non-endemic world, there are hints about the possibility that it is TB. Therefore, there's a collaborative ocular tuberculosis study was initiated. So this is a two-step Delphi technique where we gather 81 international experts. I think I also met Dr. Yuan there in Chandigarh in 2017, and also is most likely TB. The first one is serpiginous-like choroiditis. So this is a fluffy, whitish, yellowish lesion in the back of the eye, and we can see a bit raised edge. And it is different from the serpiginous choroiditis because it doesn't touch the papillary, and usually if it's healed, it gives a hyperpigmented lesion in the middle of the lesion. And then the second one is multifocal choroiditis and unifocal choroiditis. And the last one is tuberculoma. And our consensus was very much that in serpiginous-like choroiditis, anywhere in the world, if we found this kind of lesion and then either TST or IGRA positive, we already think about starting ATT. And also for tuberculoma, it is much more easier, either TST or IGRA positive, we start ATT. Or in endemic country, we don't have to have a TST or IGRA positive because we found many energies after active infection, but at least there's something in the chest x-ray, then we start the ATT. But in focal or multifocal choroiditis, it's a bit difficult. We need to have more proof, either TST or IGRA positive, but we have also to see abnormalities in the chest x-ray. So this is the consensus reached among the 81 specialists internationally. I just want to show you, this is a case in Indonesia, female 13 years old with miliary TB, and we can see very large tuberculoma surrounded by the subretinal fluid, and on the other eyes there are multifocal choroiditis. So this is because we found active infection systemically and the eye is characteristic with tuberculoma, and we just give the ATT and it improved instantaneously. And this is also proven in China, where they look for all tuberculomas, and they found tuberculomas usually found in young patients and have systemic active infection. And also, we also found it in a patient with immune deficiency. In 2012, we published a study where patients with HIV negative tend to have less granulomatous inflammation, while in HIV positive, we tend to find posterior uveitis, and it is granulomatous. And a treatment with ATT will have a good outcome. And this is also found in a retrospective study by the COTSCON group, where the ATT is less of having a failure. So patient with choroidal granuloma will have less failure with ATT compared to other type of posterior uveitis. So that is almost certain. If we found choroidal tuberculoma, it is due to TB. What about occlusive retinal vasculitis? This is an example of patient in Indonesia that we have occlusive retinal vasculitis. And after we treat with ATT, it's really good. And we have also studied by Dr. Gupta that found tubercular vasculitis, if it's associated with vitritis and focal choroiditis, we should start ATT. But generally, in vasculitis, ATT response is ferret. And also it is seen in the consensus that we are sure it is an absolute consensus if the active retinal vasculitis happen in endemic countries. So what about the anterior, intermediate, and panuveitis, where it is not too characteristic? In Singapore, Prof. Chi Soon Paik found that if it is having IGRA positive and TST positive, and there is extensive posterior synechia or atheroscleritis, then it will be better with ATT. And also in the consensus, we found that anterior uveitis, if it is recurrent, then we might start ATT. What about the intermediate uveitis? There's no absolute consensus. While in panuveitis, if the PPD, the IGRA, and the radiology is positive, even in endemic or non-endemic, we better start ATT. So after we decide whether to start ATT or not, don't forget to follow up this patient, because follow-up will give you hints about the possibility of ATT. So what happened? It could be there is a persistent inflammation, worsening inflammation, or improvement of inflammation, which what we expect, a remission of the uveitis. But there could be a recurrent. So if it's persistent, we have to think, is it really TB uveitis? We have to go back again, like what Dr. Don said, go back again and look whether this is really due to TB or other cause. Is the dosage is already correct? Is the patient comply with the medication? And this is the hardest question to be answered, is the MTB resistant to TB? And the other side is with TB uveitis, they will, patient sometimes give extra immune response, and we need to give extra steroid and immunosuppression, like in cyprigeneous choroiditis and intermediate uveitis. This is a good study by Dr. Basu, where he found there is progressive ocular inflammation even after ATT, especially in intermediate uveitis and cyprigeneous like choroiditis. In this patient, the inflammation will be better after they increase the corticosteroid. So they don't only need ATT, but also steroids, extra dose, and also other medications such as Imuran, azathioprine, or even in this case report, they will resolve the inflammation with dexamethasone intravitreally or even intravitreal methotrexate. And you have to remember about the paradoxical worsening. This is a case report about after starting ATT, 4 days afterwards, the inflammation is getting severe, while this is really due to TB. But after addition of systemic steroid, the inflammation is getting better. So don't forget about the Jarvis-Herxheimer's reaction. And after the inflammation resolved, Dr. Basu also report that there are many recurrence, and it is much more recurrences in the anterior or uveitis. And this is usually resolved only by giving topical steroids. So in conclusion, how do we approach TB uveitis when we are confused whether to give ATT or not? Please look for the predictive clinical signs and choose the diagnostic test wisely. So you can almost be sure if it is tuberculoma or cyprigeneous-like choroiditis in endemic countries, and also occlusive retinal vasculitis in endemic countries. And if it's not unresponsive, if it's unresponsive to ATT, you have to think, is it really TB uveitis, whether the drug is properly taken, and then whether it is resistant. And you have to think about paradoxical worsening, and also think about getting the patient more immune suppressed, because sometimes TB can induce immune reaction. Thank you. I would like to thank my colleague in Infection Immunology Division. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Rina, for your very comprehensive talk regarding tuberculosis uveitis. Of course, this is an important ocular complication of tuberculosis, which is still highly prevalent in our country as well as many parts of the world. So we will invite questions from the audience. Please write down your question in the Zoom chat or YouTube comment section. We will have our last speaker, but of course not least, Dr. Mutmainah. She is again my colleague from Department of Ophthalmology, RSCM Kirana. She is currently our ocular oncology consultant. She underwent her fellowship in oculoplastics from Leicester Royal Infirmary, UK. And she is the treasurer of the Indonesian Ophthalmologist Association, or Perdami, and also a member of both the Indonesian and also Asia Pacific Society of Ophthalmic Plastic and Reconstructive Surgery, or INASORPS and APSORPS. Dr. Nina will talk about a topic that many times is confusing for us ophthalmology practitioners, which is posterior segment malignancies. So please, Dr. Nina, time is yours.
Thank you, Dr. Gitalisa, for the warm introduction. So, good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. First of all, I'd like to thank the organizing committee, both from RSCM, Kirana, and NUH for this opportunity. So this morning, my talk is about when is a lesion that we found in the posterior segment is actually a sign for us that malignancy is involved. And this is more like sharing of clinical manifestation that we all might overlook in our everyday in the clinic. And also maybe continuing the last slide from Dr. Rina Ladis, is it really TB? Because most of the time TB and a malignancy can be intertwined and may take times for us to finally get definite diagnosis. So my talk today will be limited to cover the lesion that is found in adult. And keep in mind that in children, this lesion would always alert us toward retinoblastoma, but not so true in the adult. So first of all, I'd like to start with a presentation, the presentation with a case. This is the case I just encountered around 3 weeks ago, and it was consulted to me from our retina service. A male 52 years old with a complaint of blurred vision of the right eye since 3 months. Since 3 months, it was around 6 months ago when the patient first came to RSCM Kirana. So the visual acuity was of the right eye was 6/18, and the left eye was good with normal IOP. The anterior segment is unremarkable. There was only drusen and SRF positive in the right eye, and only drusen positive in the left eye. These are the OCT. There was no fundus image recorded at the time, but we can see here on the top right image that there is already CRF and slightly enlarging choroidal underneath. The assessment was AMD with the differential diagnosis of CSR. The patient was then given anti-VEGF injection for 3 times. So after 3 times ranibizumab intravitreal injection, the visual acuity of the right eye is still deteriorating. It becomes half-meter finger counting now. As we can see also the OCT, it is slightly worsened with the RPE dysfunction with the lump bump surface of the choroid and the subretinal fluid on the overlying suspiciously raised choroid. While on the left eye, it is still unremarkable and the visual acuity was still 6/6. And like all of us on the earth, the patient went on the COVID-19 break and we don't see him anymore. We don't see him for 1.5 months. So 2 months after the last injection, around 1 month ago, the patient came with the complaint of blurred vision of the left eye since one month. At the time, the visual acuity of the right eye was already light perception. The left eye became 6/18, which previously was good, 6/6. And at this time, patient was consulted to our service in the oncology division. The retina, both eyes look similar, like leopard skin. And there is infiltration under the RPE and causing the PE clumping and atrophy. And also the OCT showed a lumpy appearance of the choroid. There is a pigment epithelial detachment with bilateral subretinal fluid overlying again, suspiciously raised choroid, but this time in both eyes. And this time we highly suspected a malignancy. So we revisit the history. The patient is non-smoker and otherwise healthy, but then he admitted of a mild backache and a gastric upset since 1 year. But otherwise, he said otherwise is healthy. So he did routine checkup 6 months ago. Just before that, just before the visual acuity of the right eye become deteriorated, and the result of the routine checkup of the chest X-ray and abdominal US were unremarkable. Nothing was found in the chest X-ray. So we did ultrasound at that time. We found a bilateral subretinal fluid, choroidal diffuse mass formation. It's diffuse with high reflectivity and no sound attenuation. So because the patient already done routine checkup only 6 months ago and everything was good, we suggested him to do laboratory blood test with tumor markers. And it turned out that the tumor markers were highly positive for the CIFRA and for the CEA, which is strongly suggestion for lung cancer. So then we proceed with whole body exam for the primary site and the metastasis. The chest ray result confirmed with the CT chest, the CT scan of the chest, and suggestive of lung carcinoma with pulmonary and also the distal metastasis. So the abdominal US also suggestive of metastasis to the liver and the adrenal gland. And surprisingly, the bone scan showed suggestive of multiple bone metastasis, including multiple sites in the cranium bones, in the spines, in the chest, ribs, hip, upper arm in the left humerus, and the upper leg in the upper femur. So at this point, I'd like to think cancer is like a mafia or a mob when they almost be exposed, then the symptoms occur. So at this time, the patient suddenly feeling pain in the back, and then difficulty of breathe, just a mild one, and then pain also in the stomach. Well, just before the patient see the result, he was feeling otherwise healthy. So in this case, the blurred vision was the only initial symptom of the lung carcinoma. So is it rare? Just several clicks away from Google and some literature research after that, it turns out there are lots of case reports with similar appearance of fundus imaging and OCT that stating bilateral simultaneous central serous retinopathy as a presenting sign of metastatic lung adenocarcinoma. Further digging up, we found even 5 in 10 cases the cancer cell itself is never to be found in the intraocular. So in true malignancy, there is primary and secondary. The primary one is the uveal melanoma. In the posterior segment, we can see as the ciliary body melanoma and the choroidal melanoma. And there is also primary intraocular lymphoma. And for the secondary, there is choroidal metastasis, secondary intraocular lymphoma, and retinal metastasis, which is extremely rare. So for the purpose of the talk this morning, I would like to emphasize the one that is more often, that is uveal melanoma, the choroidal metastasis, and the primary intraocular lymphoma. So just a reminder again of if we see suspicious lesion of the choroidal mass, there's a benign. It can be benign and malignant. And this benign lesion most of the time is asymptomatic and only found as a coincidence in the fundus exam of the in the clinic. And there's also sometimes non-specific, non-neoplastic conditions that Dr. Down and Dr. Rina Aladis may have presented that mimic a tumor, that is granuloma of tuberculosis, posterior scleritis, exudative AMD, and consolidated hemorrhage that may sometimes in the ultrasound look like a clump and form as a mass. And there's also the malignant one, which is melanoma and metastatic lesion. So choroidal melanoma is one part of the uveal melanoma. Uveal melanoma consists of iris melanoma and ciliary body melanoma, but uveal melanoma concludes about 90% of all. And fortunately, is very rare in our race compared to Caucasian race, where we can find 4 to 10 cases per million people. In Indonesia or in Asian race, there's only a quarter to 1 case per 1 million. Although rare, it is very highly malignant and life-threatening, and its potential hematogenous spread to distant metastasis. With female, the same as male, and usually affect young adult and elderly. So this is the clinical features. It's painless initially. Pain may be present, but mostly painless. The onset can vary, and if not centrally located, can be very delayed. Visual impairment when central vision is affected or in larger tumor size, and it can be varied in size, pigmentation, and growth pattern. We see more clearly in these pictures. It can be melanotic or amelanotic, although we might remember that melanoma itself, it means that the tumor has to be pigmented, and you will see the dark pigmentation in the fundus. It's not always like that, especially in our race in Indonesia. So it's a dome-shaped or mushroom-shaped, and then less often also diffuse, with subretinal fluid may be present. And this subretinal fluid can prove as a poorer prognostic factor. The location can be in all quadrant, but 73% is from the equator to the macula. So this is the choroidal melanoma ultrasound. The highlight in the ultrasound of the melanoma is, it is very characteristic. That is low to medium reflectivity in the A scan. If you can see the arrow of here, it is low to medium reflectivity. And then there is sound attenuation, which means the spike from the A scan, the first strike is quite high, and then it lowers down. And then the B scan, we can see the shape is collar button or dome shape with solid consistency. And then there is a acoustic quiet zone with sometimes we can also see subretinal fluid. And this is also the ultrasound. If we want to do serial ultrasound scans, for monitoring for progression of the lesion, we have to do it in the same ultrasound device, the same operator, and we have to measure whether how is the height, how is the base, and the thickness of the tumor. So. So in the OCT finding, we can see subfoveal and subretinal fluid with the characteristic of shaggy photoreceptors, the dome-shaped choroidal mass, and overlying outer retinal thickening. So Dr. Shields and et al. Postulated mnemonic to make us easy remembering which lesion that should alert our warning towards malignancy. That is to find small ocular melanoma using helpful hints daily. That we need to find out the thickness, because thickness more than 2 millimeters and fluid, subretinal fluid in the lesion, and the symptoms, whether the size is big. We can see it from the symptoms. And then the funduscopy, we can see whether there is an orange pigment or not. And the location, whether it is around less than 3 millimeters from the disc. And then we can see the ultrasonographic hollowness, the one that I just told you about the ultrasound. And then the halo absent. The more risk factors that is found, then the more highly it is a malignant lesion. So later stage, the tumor gets larger, and there's there can be extrascleral extension. There can be complication like glaucoma, iris neovascularization, hyphema, and most that we feared of is the invasion of the orbit that we can find in the CT scan, just like these pictures over here. So we're not going to talk about the therapy, but in short, modalities option in Indonesia is still limited. And sometimes if we talk about choroidal melanoma, it's about life survival, whether it's with ocular or site salvage. And we need to work up on metastasis, as metastasis can happen anytime in the patient's lifetime. So it is a lifetime observation. So how about the secondary malignancy? Choroid is the most common ophthalmic site of metastasis due to its highly vascular tissues, and it provides a vascular avenue for tumor emboli to sequester, and that would allow environment receptive to the tumor growth. So the first case of choroidal metastasis go back to 1872, and it was considered rare, but it is not anymore. It is the most common ocular malignancy with the increasing survival rates and better diagnostic tools, it even higher incidence reported that we may have underdiagnosed it in a daily practice. The first sign of systemic malignancy as choroidal metastasis can be up to third in patients with cancer. And these are the most primary sites that is mostly found as a choroidal metastasis. Firstly is breast in a woman and lung. So if we see patient with suspected of choroidal metastasis, of a patient with choroidal metastasis, there are always two types of patient. The first one is patient with already known primary cancer sites. Anytime in the patient's life, whether the cancer was happening right now, whether he or she is in the chemo, or whether the cancer is already happening 5 years ago without any recurrence. We should always consider first any new visual complaints of the patient as a choroidal metastasis, especially if the patient has lung and breast cancer previously. So we have to do meticulous screening. Or in patients such as those that Dr. Don and Dr. Ladis has presented without any cancer-related history, but the signs and symptoms, and even after causative definite treatment of infection and in other inflammation still did not respond, then we have to think and keep in mind that one of the differential diagnoses is choroidal metastasis. So these are the symptoms. Can be blurred vision, sometimes with pain, but 15 to 20% is asymptomatic and discovered only by routine exam. So we may have to think whether we need to screen all the patients, especially with lung cancer and breast cancer. So these are the pictures of choroidal metastasis. Maybe we can see it in here. It can be seen as a creamy pale yellow color or a lobular creamy white color. It sometimes depends on the primary sites. This at the bottom is the leopard skin, which is commonly found in from breast cancer and lung cancer. And this is the OCT. One of the hallmark is the lumpy, bumpy choroidal surface here, over here, and also seen in our first patient at the beginning of the presentation, with thickening of retinal pigment epithelium and overlying subretinal fluid. And there's compression of the overlying choriocapillaries, which maybe we can see in better types of OCT. So this is the USG. So compared to melanoma, it's diffuse, lower height to base ratio, and only high with high and medium reflectivity, different with melanoma, which is low to medium reflectivity, with little or no sound attenuation in A scan. Okay, so if we suspect a patient or we suspect a lesion that is a choroidal metastasis, we have to search for the primary sites. In male, we should see through in the lung or prostate or skin. We can check for tumor markers, for instance. And for female, we need to search for the possibility of breast cancer, lung, and skin cancer. And we need to consult to an oncologist to help us find the primary sites. So this is the last one, primary intraocular lymphoma. It's a very rare neoplasm, and it's most of the time masquerading, mimicking vitreoretinal or choroidal inflammatory disease, where it looks like a chorioretinitis lesion, and the OCT showing undulating cystic tumor surface with overlying subretinal fluids. The diagnosis needs a multidisciplinary approach, as most of the time it is very difficult, and the treatment consists of chemotherapy and radiotherapy. I myself never come across to intraocular lymphoma, as it is almost always mimicking the uveitis, but the Dr. Ladis here, Dr. Rina Ladis here has presented a poster on primary intraocular lymphoma. It is a 52 years old woman with decreased vision and floaters in both eyes since 4 months. So I couldn't agree more with Dr. Down at that uveitis specialist should be an excellent detective. And as with every uveitis specialist, all the investigation were already done by Dr. Rina, and it turns out negative. And the histopathological analysis and radiology examination is also turns out inconclusive. But the vitrectomy specimen is taken. The result was also still inconclusive. There is only a small clump of lymphoblastic cells suggestive of malignant lymphoma, but the pathologist with that result alone cannot really make a definite diagnosis of lymphoma. So, the visual acuity was deteriorating at that time. So Dr. Rinaladis did intravitreal injection of rituximab, which is an anti-CD20, which is used mostly in lymphoma. And we can see here before the injection, the retinitis-like infiltrate with hemorrhage and yellowish perivascular infiltrate. And after the injection, the visual acuity is improving. So close observation to development of CNS lymphoma is also important. So why is it important to read the warning signs? In choroidal melanoma, what could happen if we're late or wrong? Choroidal melanoma has high mortality rate, and the risk of tumor dissemination in mistreatment surgical procedure is high. The risk of metastasis is high. So delayed diagnosis will lead to bigger growth, will lead to complication, and will lead to less option for ocular preserving treatment. While in choroidal metastasis, the primary site of cancer will silently grow and cause complication. And if we're late or wrong, failure to determining metastasis means failure in determining tumor staging. So we need to help our friends oncologists in internal medicine. And also if we're late, the prognosis is very poor. The median survival rate was only 6 to 18 months. And these are some of examples that we encounter in the clinic. So both young male, they both routinely did the eye checkup for over a year to an ophthalmologist for the complaint of blurred vision and redness of the eye. But still it was missed, and the diagnosis of choroidal melanoma has costed their orbit, because at that time, enucleation is not an option. The tumor has already invading the orbit, and we need to do exenteration. And they're young. And this is another case. The patient was came to us, as we can see here. The previous ophthalmologist make a diagnosis of total retinal detachment, and vitrectomy and silicone oil injection was done. As we can see here, there's a silicone in the anterior chamber. We can see the sites of the vitrectomy, and it turns out that it's melanoma with higher risk of hematogenous spread and higher risk of extrascleral extension. So actually this patient came to us already 2 months earlier, and at that time the diagnosis of choroidal melanoma was already made, and the patient was already suggested for enucleation, but the patient never came back to us and went to other hospital, and the retina consultant diagnosed it and did the vitrectomy. So I think it's a valuable lesson, both for me, so because I need to do a thorough counseling, patient education, and understanding of the disease. And please always do ultrasound in total retinal detachment cases. This is a case where seven eviscerated sample turns out to have melanoma intraocularly. And one of the case in this series is passed away 4 months after the evisceration. As we know, any evisceration, any iatrogenic procedure can make tumor dissemination of the melanoma. So when in doubt, please do imaging, whether it's a ultrasound, MRI, or CT scan, and when in doubt, do enucleation. I will just skip this, and this is my take-home messages. So keep in mind that there is a possibility of malignant involvement in every posterior segment lesion. And back to the epidemiology, where choroidal metastasis is much more than choroidal melanoma, and then rule out any infection or inflammatory process. So you have to be responsive if the patient does not respond to therapy, and look for other signs, locally or systemically. Revisit again all the history and result, and really ask the questions, the right questions to the patient. Bilateral involvement and atypical appearance should alert suspicion to metastatic lesion, and collaborate. Dr. Rina Ladis and I, we collaborate most of the time for the making diagnosis of intraocular tumor, and also with our retina service team. And also with internists, oncologists, pathologists, and everyone to give a holistic management for the patient. And then record. And especially in malignant lesion, these patients especially need us to help find diagnosis as early as possible, because it really depends on the survival rate. These are the references. Thank you very much for your attention.
Thank you, Dr. Nina, for a very clear and detailed talk regarding posterior malignancy. Of course, it will be useful for us practitioners to be aware and help us diagnose posterior malignancies. We will invite all the speakers. I have here at the studio Dr. Rina Ladis and Dr. Nina Mutmainah. And let me also greet Dr. Don Lim. Are you still with us?
Yes, I am.
Yeah. Hi, Dr. Don. So let me start by, there are many questions already from the audience. I think we have audiences both in the studio, in Indonesia, as well in Singapore, and also other countries. Dr. Rina, a friend maybe from India and other countries. So we will start with the first question. I think this is directed to you, Dr. Don Lim.
Yes.
First of all, when do we decide to propicamid 1% and phenylephrine 10% safely in secondary glaucoma due to uveitis, like mentioned in your PowerPoint, because we cannot assess the angle due to the corneal haziness? So I think that's the question.
So I think what I was sharing is secondary angle closure from inflammation. And if you look at the eye, typically these patients have almost a 360 degrees posterior synechiae. And so therefore, the primary mechanism is that of the inflammation in the eye, and hence leading to the pupil being stuck down. And this is a secondary pupil block. And it's fully justified to give a 10% phenylephrine and 1% tropicamide, even if you do not have the opportunity to assess the angles, that's fine, because the primary aim is to break the posterior synechiae. And hence you have addressed the root cause. Because all rules for primary glaucoma management just breaks down in the management of uveitis with raised intraocular pressures. So there's no need to assess the angles when you have an inflamed eye, pupil block. You know that there's fibrin plaque there, it's hypopian, young man, posterior synechiae. Just give the dilating drops to break the posterior synechiae, because we do have only a golden window of opportunity to intervene. If you do not break the posterior synechiae, most of the times when the posterior synechiae is left there, it becomes chronic. There's no way that we can lyse it, and we have to go in surgically to do a iridectomy. Does that answer the question?
Yes. Thank you very much. Any comments maybe from Dr. Rina Ladis? Do you also give a similar treatment to your
your patients with secondary glaucoma and uveitis?
Yes, the problem is, Dr. Gita, the patient that came to us usually already chronically, so we have occlusion or seclusion, so it's kind of hard to do only topically.
Yes.
Yeah, but I agree with Dr. Don. If we see it acutely, then we have to immediately dilate the pupil.
Yes, I think that's the priority. Yeah. I have another question for you, Dr. Don Lim.
Yes.
Is there any place for torch serology tests for uveitis patients, especially posterior uveitis and panuveitis? Or do
Yes,
you still
definitely.
routinely do, or in all your patients presenting with symptoms?
Mm. So alluding to my talk earlier on, we have to really assess the etiology or the most likely etiology based on the presentation, the symptoms, starting from the history, symptoms, and examination. And if really in panuveitis, sometimes if the media is very hazy, there is no way we can see what's happening in the retina. I think it is fully justified to go ahead and do an aqueous tap and send it out for viral tetraplex to exclude a infective etiology. So in our institution, we do send off for panuveitis sometimes when it precludes, the vitritis precludes all view of the posterior segment. We still send off an anterior chamber aqueous sample. So anterior chamber tap for aqueous sample for viral tetraplex. So that is what we do. So in the viral tetraplex, we test for toxoplasma, HSV, VZV, and CMV. Does that answer your question too? Yeah.
Yeah. So let me clarify. So you, in many cases, you will do a PCR test to the anterior chamber tap or vitreous tap for these cases.
Yeah, for this specific
the
cases in whom we are suspecting or we want to exclude first an infective etiology, especially for panuveitis, we would do an anterior chamber tap.
Okay.
Yeah, because an aqueous
Yes.
tap will yield the same as a vitreous tap, and it's actually less invasive as well.
Okay, maybe Dr. Rina, you want to comment on this?
I totally agree with Dr. Don. This happened in Indonesia because we only recently have PCR testing from the aqueous tap, and therefore usually we do the torch serology. But you have to remember uveitis, first of all, history taking. History taking is really important, and also physical examination, because most of the clinical manifestation is characteristic for these kind of infection. For example, the toxoplasma, we have headlight in the fog, and then for infectious uveitis, such as the viral disease CMV, HSV, and VZV, they have clinical characteristic. So when we do torch, it is only useful if it's negative. So if the IgG is positive, the IgM positive, then it doesn't give us any kind of hint. It is better to go directly to do PCR if we see that from the history and also the physical examination, we suspect more infectious cause.
Very, very clear to us. Dr. Don, I have one other question for you. When do you do UBM examination? Or do you perform UBM in most of uveitis cases with secondary glaucoma? Do you routinely do the test?
Okay, so going back to my talk again, I don't routinely do any of these investigations. So for that case in which I shared, that gentleman was initially managed, if you recall my mentioning, for possibility of aqueous misdirection before he was sent to us. So the UBM images were already obtained at the time when he was sent to us. And if you look at the history, actually, if this is sympathetic ophthalmia, then you're thinking actually of a ciliary body or a posterior process that results in a secondary angle closure. And hence the ultrasound biomicroscopy in this case would be justified because only UBM can show you what's going on behind the iris. And in this case, it illustrated, if you recall the images as well, the ciliary body swelling, the cystic changes, and how it improved and how the swelling decreased with intravenous methylprednisolone. So to answer the question, no, I do not routinely perform UBM, but again, based on circumstance, or sometimes in cases with, let's say, juvenile idiopathic arthritis, and we notice that the pressures are persistently lowish, we might want to consider doing an ultrasound biomicroscopy because the UBM might show cyclitic membranes, or perhaps maybe because if the inflammation is not well controlled, we might see a ciliary body swelling there, and that might guide us in terms of increasing the immunosuppression. So that really depends on the indications and the circumstance in which we order or proceed with UBM. So again, it's not a routine test.
Yes, thank you. So it depends on your judgment, yeah, for certain cases.
Yes.
Okay, let me proceed to questions to Dr. Ladis, but of course I would ask Dr. Don Lim and Dr. Nina for comments. So the question for Dr. Ladis, first one is, what do you think about TB with isolated ocular manifestation without any other systemic findings? Will you give ATT by yourself?
Okay, thank you, Dr. Gita. This is a really good question. But my policy is if we give systemic medication, I always collaborate with our internal medicine doctors. Why? Because even though it is isolated in the eye, our colleague also need to know what are the manifestation of extra pulmonary of TB. Because if they spot the patient first, they would know when to refer to us. So if it's all isolated in ocular manifestation, I definitely will collaborate with internal medicine.
How about you, Dr. Don Lim, in Singapore? If you find isolated TB, ocular TB, would you prescribe ATT medication, or you send to the internal medicine specialist?
In our institution, we collaborate and we co-manage with our infectious disease specialists. Yeah, so we don't start it ourselves.
Yes, same, yeah. Okay, let us move on to the next question for Dr. Ladis. How do you differ paradoxical worsening of from TB uveitis from non-TB uveitis?
Maybe I'll try to rephrase the question. So if there's a worsening, how do you know it is a paradoxical reaction, or it is actually not a TB disease? So actually, if we think it is a paradoxical worsening, we need to be sure that this is actually active TB infection. For instance, the clinical manifestation is granulomatous, or we found a really infectious MTB somewhere else, for instance, like meningitis from the brain, or really severe lung diseases. Then when we give ATT, it induces paradoxical worsening because our immune response is not capable of facing lots of that MTB. Therefore, the paradoxical worsening happens. So we are sure that it's due to TB, and because of the treatment, it induces severe inflammation because of the MTB itself. But if we see there's a worsening, but we were not sure about the presence of active TB infection, then we should start to think this is a non-TB uveitis.
How about you, Dr. Don Lim? How do you differ? Is it TB uveitis with paradoxical worsening, or is it a non-TB, in fact, a non-TB uveitis?
I think it really depends on tying up what we find, like what Dr. Rina said, what the findings are that led us to the initial diagnosis of TB uveitis, and hence the initiation of ATT, isn't it? And certainly, if you're concerned about a Jerisch-Herxheimer reaction or basically post-ATT induced inflammation, there is sometimes no harm to start a little bit of systemic steroids. This typically manifests itself 2 weeks after the commencement of ATT. So systemic steroid is something that you can stop fast because it's just given orally. So I would always recommend that if one is unsure, start with something that you can stop easily. So again, the principle lies on what was the initial etiology or the initial premise that results in the ATT being warranted. So if we truly think that this is a clinical, this is actually clinically a TB uveitis, then certainly, I think one should just go ahead and treat the paradoxical reaction. But as what Dr. Rina has shared as well, if let's say the patient still fails to improve in spite of the treatment, then we really have to take a step back, hold our horses and think about what the other possibilities or reconsider the differential diagnosis. So there's no clear answer here, to be honest, as for some things in uveitis.
Okay. Well, thank you. Once again, we're reminded that clinical diagnosis is the most essential. One more question for Dr. Ladis, and I think for both Dr. Ladis and Dr. Don Lim, may I be shown the Dr. Ladis set of questions? So I think for both speakers, when should we consider our diagnostic investigation is enough and consider an unknown cause of uveitis is idiopathic uveitis? And in what settings should we keep on trying to employ further diagnostic procedure?
Thank you, Dr. Gita. This is also a good question, and it's always asked for me. So the principle of uveitis is we try to maintain the function of the eye by stopping the inflammation, because each time there's an inflammation, there will be a destruction of the intraocular tissue. So the mainstay treatment actually to observe that and to make sure by giving anti-inflammatory drugs. So to make it simple, we just need to exclude the infectious cause, because if we give anti-inflammation drugs without covering the infectious cause, then we'll be in trouble. So in Indonesia, for instance, our infectious cause, the first one is toxoplasma, and the second one is TB, and the next one is the viruses like CMV, HSV, and then the last one that is really masquerading is the syphilis. So we have to keep an eye on that. So if we are sure that this is not an infectious disease, especially if the clinical manifestation is more likely to the non-infectious one, therefore we need to recognize all those 30 kind of uveitis by heart, so we can know. Then we are safe to give this steroids, anti-inflammation, or only to observe as long there's no worsening of the visual function.
How about you, Dr. Lim? I think in Singapore also there are a lot of more infectious cause of uveitis compared to idiopathic one.
So, sorry, just to understand the question better, it's on basically, can I just clarify the question? That is asking how far do we go about how far do we go with investigations if repeated tests return negative? Is that correct?
Yes.
Yeah.
Yes, correct.
So
yeah.
So for most of my patients at initial presentation or at their first presentation, again, guided by the history examination and what I find or see in the eye, I would usually advise the patients or tell them that we do not carry out all tests. However, in future recurrences, as the signs or the symptoms start to evolve, we might have to do further investigations. Okay, that's the first thing. So my initial investigation will be guided by what I see clinically and from the history. The second consideration would be guided by the clinical examination as well. So if you certainly we see posterior synechiae, the type of posterior synechiae, granulomatous capes, then we certainly need to exclude possibilities of tuberculous uveitis, sarcoid. So our differentials actually change totally. And however, I must admit that sometimes, the investigation results do come back negative. So if they're negative, that's fine, because you have done your due diligence in excluding an infective cause. And do not forget the masquerades, such as syphilis that Dr. Rina has correctly pointed out, because syphilis is a great masquerade that can present itself in any manner. Okay, so this is one of the serologies that I do send out. So I think aside from that, if you would like to go ahead and give a trial dose of topical steroids, that's fine. Again, the next principle would be to start something that you can stop easily. Don't go on and do intravenous or intravitreal Ozurdex, because once an implant is in the eye, you can't take it out. So you can always judiciously give topical steroids, even systemic oral steroids where warranted, because these medications can be more easily stopped than an intravitreal local delivery of intraocular steroids. Okay, so there are certain guiding principles in which we adhere to. But again, all that is based on patient's presentation, history, and examination.
Yes. Thank you, Dr. Dawn. Let's move on to Dr. Nina. We also have many questions for her. Is there any way to differentiate between choroidal melanoma and choroidal metastasis by ophthalmological examination?
Okay. So some yes, but most of the time it is quite difficult. Our first clue is the duration or the onset of the symptoms. In uveal melanoma, usually it progresses, and in choroidal melanoma, and it grows quite slowly rather than the choroidal metastasis. In choroidal metastasis, it depends on the primary sites, but some cancer, such as in lung cancer or breast cancer, it can be as fast as 2 or 3 weeks or months. While in uveal melanoma, sometimes we can still see patients with slow growing within 1 to 3 years. Although during those time, the growth of the tumor itself has already so big. And then the second one, if the lesion is the same small lesion, then there are some clues that we can find from the clinical manifestation of the fundus lesion, such as the shape. The choroidal melanoma usually is more thick in terms of the height, from the height to base ratio compared to the ones in choroidal metastasis. And we can have some clues from the ultrasound finding the shape, also the dome shape or the reflectivity of the A-scan usually is low to medium for choroidal melanoma and high to medium for choroidal metastasis, and also in OCT. Although most of the time it we can see melanoma that sometimes we're not sure whether it's melanoma, and then we can see patients with choroidal metastasis that we're not sure it is a metastasis. Yes. Yeah.
Okay, thank you, Dr. Nina. I think related to that question, could we go back to the first slide? When do you decide enucleation in choroidal melanoma compared to other treatment modalities?
Okay, so unfortunately, the treatment modality is very limited in Indonesia. At this time, we still don't have any brachytherapy plaque, not to mention the photodynamic therapy or proton beam radiation, which all those three have already proven to kind of cure, in quotes, the melanoma itself. So at this time, if we find small lesion of suspected choroidal melanoma, we do a very close observation. As with all the tumor, melanoma is, we can see the growth. So we do series of close observation for the fundus examination, for the ultrasound examination and the OCT examination. As soon as we found the proof that it's growing and the clinical appearance has already make us sure that it's a melanoma, then we do enucleation. Usually we take times, but any subtle changes during the waiting has raised our alertness to melanoma. So then we act.
So do you do that quite, I mean, encounter those kind of cases quite often here?
Yeah, in 3 years, we encountered 4% of all 4%. The cases of malignancy in our hospital.
And the patients usually would comply to your plans?
Yeah, as I mentioned in the last case, it's also a lesson for me still to give understanding and education and better counseling for the patient, that it is an important salvage treatment that we need to go through. Yeah.
Okay, so I must apologize that there are still many questions. Hopefully, maybe Dr. Lim, Dr. Rina, and Dr. Nina could answer them through other media. Yeah, and but that's the time we have for this session. Once again, I would like to thank all the speakers, the excellent speakers, Dr. Don Lim, Dr. Rina Ladis, and Dr. Nina Mutmaina for their excellent presentations. And I think we should give a big round of applause for them. And we will see you at the second session shortly. So that's from me. Bye-bye, see you.
Hello, welcome back to the second session of the third collaborative webinar series of RSCM Kirana and National University Hospital of Singapore. Again, I'm your moderator, Dr. Gitalisa Andayani. In this session, we will talk more about posterior segment pathologies. And allow me to introduce our first speaker from NUH, Singapore, Dr. Yuan Yu Sen. He is a consultant and holds various positions at of ophthalmology at the Yong Lulin School of Medicine, National University of Singapore, as well as faculty of the NUH Hospital Singapore. He is currently the ophthalmology residency program core faculty, and also adjunct teaching faculty of Lee Kong Chian School of Medicine, as well as special advisor of the National University Polyclinic Specialty Advisory Group, and information technology representative of Alexandra Hospital, the Next Generation Electronic Medical Record Project, Singapore. So I think without further ado, I will ask Dr. Yuan Yu Sen to deliver his speech. So you can share your screen now, Dr. Yuan.
Thank you very much for the introduction. As I'm sharing this, and it's very nice once again to see Dr. Ladistia, Dr. Nina, and thanks to Dr. Yulinda for the invitation for this. Can you see my slides?
Yes.
Yeah, all right, great.
Very clear.
Okay, good. So good morning, everyone, and selamat pagi to all my friends and colleagues in Indonesia. Thanks again for this opportunity to share my talk on fungal endophthalmitis. So I'll start with a case presentation of one of the cases that we had. So this is a 27-year-old Chinese gentleman who comes to us with a past medical history of HIV on medication. 6 months prior to his presentation, his CD4 count was 561 cells. This is actually quite a good level. He's also got a history of syphilis with 3 doses of iron penicillin, which was treated with 3 doses of iron penicillin. And now he comes to us with a complaint of left more than right eye painless blurring of vision for 3 days. He also tells us that he has defaulted on all his HIV medication since 6 months ago due to cost issues. So 6 months ago, his CD4 count was very good, 561, but he has now stopped all his medications for the last 6 months. On examination, we have his visual acuity at 630 and 1/60 in the left eye. Intraocular pressures are normal. There's some inflammation in the anterior segment. The lens is clear. There's no synechiae. He looks well. He's afebrile. He's got no other systemic complaints. He's walking around the clinic looking completely healthy. On the fundus examination, as you can see here in the optos, there are retrolental cells in both eyes, more in the left eye compared to the right. There is this little yellowish lesions that you can see around the fovea, around the macula in both eyes, worse on the left eye. And when you do an OCT, you see these lesions. Now, the one in the right eye appears to be intraretinal, and the one in the left eye looks as though it's coming from the choroid. So the concerns at this point, I mean, this is the first time we're seeing a patient. We don't know what his CD4 count is right now. His last CD4 was 561 6 months ago, but he has stopped his HIV medication since then. If you want to repeat the CD4 count, it's going to take 3 to 5 days for the CD4 count to return. But unfortunately, the CD4 count will influence the types of opportunistic infections that we suspect, depending on what his current counts are. It will also influence the immune response that is seen clinically, meaning that if his immune system is compromised, you wouldn't expect to see the inflammation that is prominent in certain conditions such as toxoplasma. Next question is, how do we investigate this patient? And then last of course, while we're waiting for all our tests to come back, what empirical treatment do we start? So this is just a table to show the CD4 count and the types of opportunistic infections that can occur at the various levels. At the highest level, at high CD4 counts, you get things like oral candidiasis, tuberculosis. And as you go down the list, as the CD4 count keeps dropping, you get things like cryptosporidis, toxoplasmosis, cryptococcal, CMV retinitis, and so on. So the patient is admitted. We do an infective workup. This includes an aqueous tap for a viral tetraplex. And as Dr. Don has mentioned, this is a CMV, HSV, VZV, and toxoplasmosis. We also do toxoplasmosis serologies for the patient, syphilis, T-spot TB, as well as blood cultures. Empirically, over the weekend, he started on triple therapy for possible toxoplasmosis in view of the intraretinal lesion on the OCT in the right eye, as well as pending further investigations, as we don't have any test results coming back yet. So this is the photo, at presentation, the right eye, and then 3 days later, you can see that the lesion is getting a little bit smaller on the OCT as well as the photo, but unfortunately, the left eye is getting worse. Up to this point, he is well, he's got no fevers, and our investigation starts to return. Our blood cultures come back, there's no bacterial growth. Fungal cultures are pending. This will usually take about 2 weeks for the results to come out. Syphilis, TPPA is reactive and RPR is non-reactive. What this means essentially is that the patient has previous syphilis that has been treated and there's no longer active syphilis. The reason why we say so is because TPPA is a treponemal test, which will always remain positive in syphilis patients, whereas RPR, which is a non-treponemal test, will vary depending on whether the syphilis is still active. So once it's non-reactive, we consider it as treated syphilis. Aqueous tetraplex was negative, so there was no signs of PCR positivity for HSV, VZV, CMV, and toxoplasma. Toxoplasma IgM and IgG are negative, and T-spot TB is negative. So now in view of the worsening lesion in the left eye, we stop toxoplasma treatment. We attempt a left eye vitreous tap. Unfortunately, because he's a young man, we get a dry tap and we send off a left eye aqueous tap instead for culture. At the same setting, because now our clinical suspicion is that of fungal endophthalmitis, we also deliver an intravitreal voriconazole 100 micrograms and 0.05 mils to the left eye. And in consultation with our infectious disease colleagues, the patient is also started on IV penicillin as well as IV endilafungin empirically to cover, in fact, to cover everything, because at this point, 2 or 3 days into the presentation, we still have no idea what the underlying organism is. So this is 3 days after that. Now the right eye, which was initially getting better, is getting worse. So we give intravitreal voriconazole to this eye as well. Fellow eye perhaps getting a little bit better, but then to increase the ocular penetration, we changed the IV endilafungin to voriconazole 200 mg/BD. And this is real life, so we do other tests as well. So we did an ultrasound liver to look for other possible sources, because essentially what we are trying to do is we're trying to find something that we can tap to get a positive culture. So we do an ultrasound liver. There's a 1 cm echogenic focus at the surface of the right lobe. In view of the clinical setting, it may represent an evolving abscess. Left eye aqueous taps now come back. The fungal smear is negative. Cultures are once again pending, and this will take about another 1 to 2 weeks. Blood culture, we start asking the labs after 6 or 7 days, there's still no fungal growth so far, so we still don't have any positive organism. We do a transthoracic echo, it's normal, and there's no valvular vegetation seen. Then we move on to do an MRI liver, and that lesion that we saw, which we thought might have been an abscess, turns out to be a hemangioma, so thankfully we didn't tap that. Left eye aqueous tap was no fungal growth, blood cultures, no fungal growth. So up to this point, we have a patient who is getting a little bit worse. We think it's an infective organism, but we have no idea what the organism is. We suspect fungus, so we continue on with a presumed diagnosis of fungal endophthalmitis and keep our fingers crossed. The patient is kept on oral voriconazole as well as repeated intravitreal voriconazole and amphotericin B to both eyes every 3 to 4 days. We initially considered a vitrectomy, but we held off due to the low yield expected in view of the minimal vitreous inflammation seen at the point of presentation. So now 2 weeks later, after antifungal treatment is started, you can see that things are now getting worse in the right eye as well as the left eye, despite everything that we're doing. So now the lesions are not getting better despite antifungal treatment, but now we are stuck. We're not sure whether we're truly dealing with a fungus, what organism we're dealing with. So now we decide that now, since there is fungal snowball seen in the eye, we go ahead and do a vitrectomy for this patient. So a patient undergoes a left eye vitrectomy, bilateral intravitreal voriconazole. Fungus smears are negative, but then the culture later comes back positive for Candida albicans sensitive to amphotericin B, fluconazole, and voriconazole. So the final diagnosis for this patient is bilateral endogenous Candida albicans endophthalmitis. He's a HIV patient, but with a reasonably intact immune system because of his high CD4 counts. He denies the use of IV drug abuse, and he has no needle tracks seen on examination when we first saw him. But much later on in his admission, he later confessed to us that he was actually going to prison for drug-related offenses. But he says that he didn't inject anything, and he claims that someone spiked his drink. Along the way, as part of the treatment, the voriconazole trough is done, which means that we test the blood for the levels of voriconazole, and this comes back as a subtherapeutic dose, subtherapeutic level of 0.50 mg per liter. You need actually more than 1 mg per ml, which I'll talk about later during the course of my talk. After the vitrectomy, what happened to the patient? We initially began amphotericin B as IV. This was initially held off because he had raised creatinine in his kidneys. So workup was done during his admission, and then we think that now that the raised creatinine is normal because he's actually a very muscular guy. So we think it might be just be due to increased muscle mass. We also persist with intravitreal voriconazole and IVT amphotericin B, and then we switch him to oral fluconazole on discharge. And this is the progress that you can see. As time goes by over the months, the lesion gets smaller and smaller and finally starts to respond in both eyes. And he's finally left with a macular scar in both eyes. Thankfully, he's developed some sort of peripheral fixation, so his vision is still relatively decent. So there are a lot of lessons that we learned from this case. The first lesson is this. So if you have a HIV patient, we know that the types of infections that you think about would depend on the CD4 count. But what if you are faced with a scenario like this? A patient who comes to you has stopped the medication for 6 months. It takes you about 4 or 5 days for the CD4 counts to come back. So in this time, you don't really know what to do. So this is a STOPA study. This is what is a treatment interruption study. And essentially what happened is that this first row here is the CD4 count of patients while they are on ART treatment at 1 year, 2 years, and 3 years. And you can see that the CD4 counts are quite high. This is a treatment interruption arm where patients who have stopped their CD4, who have stopped their HIV meds, you can see that the CD4 count starts to drop, but it actually takes a few, even though 3 years is 3 years later, the counts don't really drop that much or that fast. So for our patient with a CD4 count of 561 6 months ago, but he has stopped ART since then, when we repeated his CD4, it was actually 473. So even though he has stopped treatment for 6 months, actually his CD4 count didn't drop much, and he could have been considered as an immunocompetent patient at presentation, and that would have actually changed what we thought in terms of what he had, in terms of the suspect organisms. Next thing, when do you suspect fungal endophthalmitis? So this would be typically immunocompromised patients, HIV, cancer patients, organ transplant patients, patients on total parenteral feeding, central venous catheters, poorly controlled diabetics, as well as patients with IV drug abuse. In particular, for patients who are IV drug abusers, the fungemia is transient, so blood cultures may be negative, as was the case in our patient. When would you do vitrectomy surgery? So there are different stages of retinal findings that have been described. This is a very nice classification by Tanaka. So in stage 1, there is chororetinal changes without extension into the vitreous cavity. Stage 2, the fungal mass penetrates through the ILM and buds into the vitreous cavity. Stage 3 leads to a complete vitritis, such that you can't see the fundus very well. And stage 4, when it's complicated by retinal detachment. Tanaka recommends surgery in stage 2 when there's a fungal mass in the fovea, or when it's stage 3 or more, essentially when there's a lot of vitreous activity. We believe now that actually, because fungal endophthalmitis don't really do very well, and because now smaller gauge vitrectomy is reasonably safe, our threshold to go in is actually a lot lower now. So we would probably consider it in late stage 1, early stage 2, especially if you're not sure what's going on. So now when we do a vitrectomy as well as the aqueous tab, we send that off for fungal smear and culture. But besides fungal smears and cultures, what other tests can you do? So there are actually other things you can do to increase your chances of getting a positive diagnosis or positive culture or positive test. You can do a pan-fungal PCR. This targets the 18S, 28S fungal ribosomal RNA molecules, or a PCR for internal transcript spacer on ribosomal RNA. Now, this also allows for improved species differentiation between the various types of fungus. You can do a BD-glucan. This is a serum or a vitreous test to look for the yeast and fungal wall component for Candida aspergillus fusarium, or a Cantex latex agglutination test for serum, which detects circulating Candida albicans antigen. So let's try again. So let's say we have, so this is another case. So this is a young child, a 4-year-old patient with metastatic neuroblastoma, who complains of blurring of vision, and we see these lesions in the retina, and we suspect that this patient has fungal endophthalmitis. Now, the problem once again that we're faced with is when there are so many types of fungus, organisms, yeast, moles, dimorphic, as well as multiple types of antifungal drugs. What would you consider? So this is a table that lists out all the types of antifungal agents that we have. There are 4 general classes of families. There's your polyenes, which consists of amphotericin B, nystatin, natamycin, your azoles, fluconazole, itraconazole, and then your later generation ones, such as posaconazole, voriconazole, echinocandins, caspofungin, endilafungin, micafungin, as well as pyrimidine analogs, such as flucytosine. So which agent would you choose? I mean, say a patient who walks in, you think is fungal endophthalmitis. If the patient had access to all of these drugs, I mean, some of these medications are more expensive, and therefore those are cost considerations. So are the newer ones better? Something to think about, right? The next thing that you ask yourself is, what are the possible fungal organisms that you want to cover? So for the fungal subtypes, once again, there are many types. There's yeast, dimorphic, which means they grow as mole in the environment, but they change to yeast when it grows to the human respiratory tract. Mole, as well as uncertain, which is Pneumocystis jirovecii. This is previously known as PCP pneumonia in HIV patients. But actually, if you really look at it, the bulk of fungal endophthalmitis is caused by these 4 organisms: yeast or moles. This is what we are traditionally taught. Yeast are Candida and Cryptococcus, and Aspergillus and Fusarium for moles. And you can see in brackets the drug that would typically cover them: fluconazole, voriconazole, amphotericin B for these 2. Natamycin is a treatment choice of fungal keratitis, but it's only available as drops, so you can't use it as IV or oral. So this is a summary table, or is a summary slide. This is a fungal subtype up here. So if you have yeast, Candida albicans, oral fluconazole will cover yeast. For moles, you have Aspergillus and Fusarium. And your intravenous or oral voriconazole will cover both spectrums, both yeast and moles. IV amphotericin B will also cover both. So if you had a patient, back to the same scenario, a patient who you suspect has fungal endophthalmitis, what would you start? Why not just treat every patient with voriconazole or amphotericin B? I mean, if you wanted to be safe, right, you cover everything and you give them these drugs, and you would cover both sides. How about the other list of other antifungals I showed you earlier? There was a whole list: endilafungin, ketoconazole, itraconazole. So this is a really good study that I've looked through that has given us a lot of information. So the first question you have to ask is, for all those agents that we mentioned, is the vitreous penetration the same? So it's a busy slide, so I'll guide you through. X is for human data that you see over here. O is for animal data like you see down here. Yellow means that the concentration in the various structures, which is aqueous, vitreous, and cornea, ranges from more than 0.5 times to less than 5 times the plasma concentration. This means that if you see a yellow box, this has good vitreous penetration. Red box means that the level of detection is less than 5 times the plasma concentration, which means that there's poor vitreous penetration, and white says there's no data. So if you look at the whole list of medications, fluconazole, itraconazole, voriconazole, posaconazole, which is posaconazole is actually a very new one, as well as the various types of amphotericin B. The arrows in purple highlight the drugs with relatively good vitreous penetration. So if you look at fluconazole, it has good human data for good penetration in the aqueous, vitreous, and cornea. Voriconazole more for aqueous, not so much for vitreous. Amphotericin B, and flucytosine 5-FC. And then you have caspofungin here, but the reason why I did put an arrow here is because the animal data was good, but there's good human data to show that the penetration isn't very good. So if you look at this whole table, the one that really has been shown to have good vitreous penetration is only fluconazole and perhaps flucytosine, which I'll go through later as well. So when you talk about a management of a patient with candida endophthalmitis, which is say something that's susceptible to fluconazole or voriconazole, fluconazole achieves a vitreous concentration that is 70% that of plasma. So it's really quite good vitreous penetration. Voriconazole, while is very broad spectrum, the vitreous penetration isn't really that great. It's about 40% of the serum concentration. If you wanted to use the doses, I've written out the doses that we would typically use down here. Next question, say you get back your culture, your initial culture, and they said, oh, we see a yeast, we think it's candida. And candida, as I mentioned before, generally fluconazole will cover candida, but are all candida species equal? Now, if in your report, they say that the patient has candida krusei or glabrata, these two subtypes of candida are inherently resistant to fluconazole. So if you see these names, have a very low threshold to switch to something else, especially if the patient isn't responding. So candida krusei is inherently resistant to fluconazole and is usually susceptible to voriconazole. For glabrata, voriconazole should only be used if the isolate is susceptible. Sometimes there is a high cross resistance between fluconazole and voriconazole. So you must watch these patients very carefully, because if the glabrata comes out as not susceptible, then you need to switch to amphotericin B. This was a table that I showed earlier, and now I've modified the table slightly to include another table here, another box here that says yeast, candida glabrata, and krusei. And under these, you will have to use these two drugs. Fluconazole has better vitreous penetration. I've put that down here. So to answer the first question, why use fluconazole? Because it has better vitreous penetration than voriconazole, especially for yeast. It is also much more well tolerated. There is no issues. It has good gastric absorption, quite little side effects compared to the rest of the azoles. Voriconazole, while it's quite a good drug, if you take a high-fat diet, it actually reduces the absorption of the voriconazole. Voriconazole has a better side effect profile than IV amphotericin B. So and if you were to look at these two boxes, voriconazole and IV amphotericin B, why would you use voriconazole? Because voriconazole has a better side effect profile than IV amphotericin B. Next, let's talk about IV amphotericin B. So let's say you have a patient who you want to start IV amphotericin B, and you ask your ID physicians to start the drug for you. You have to be aware that there are many types of IV amphotericin B. You have a lipid-based amphotericin B formulation known as Ebosat, the conventional formulation which was used in the past, deoxycholate, and then liposomal amphotericin B cholesterol sulfate complex, which these are the various brand names. Liposomal amphotericin B has replaced amphotericin B deoxycholate due to its lower renal toxicity of liposomal amphotericin B. So this is our preferred choice nowadays, especially if the patient has poor renal function. I brought up a drug earlier on, flucytosine. Now, flucytosine actually has very good vitreous penetration, as seen in the table earlier, which I'll show you again later. It's much better than IV liposomal amphotericin B, which in turn actually has better vitreous penetration than the other forms of amphotericin B. So you have to be aware, even if you're being told that the patient has been getting IV amphotericin B by the ID physician, you have to be aware of what type of amphotericin B they're giving. Flucytosine is useful, but the use is limited because of a concentration-dependent bone marrow toxicity. And this is worse in patients with renal insufficiency. So this is actually not used that much, even though it's actually quite good. But it's something useful to have as part of your armory in case your patients don't do so well. These are the doses over here if you want to use them. And for flucytosine, as I showed you earlier, this is flucytosine 5-FC. This is not 5-fluorouracil, which is what some people have thought is 5. So this is flucytosine. Okay. Intravitreally, of
sorry,
course.
Dr. Yuan, you have 1 minute.
Sure. I'm almost at the end. So intravitreally, you have your intravitreal amphotericin B and voriconazole. These are the doses. And finally, this is what I would start. If I have a patient who walks into my clinic, I think it's fungal endophthalmitis, I will start oral fluconazole because with good vitreous penetration, it will cover the yeast. I would deliver intravitreal voriconazole and amphotericin B. And once I have culture results, I will change my management accordingly. And this is, once again, the summary slide. And the last post that I have is that you have to be careful about drug interactions. Make sure that you use, before you start all these medications, make sure that you check for interactions with other medications that the patients are on. Thankfully, most patients are young, so you don't really have all these other drugs on board. And voriconazole, very important, you must do drug level monitoring. And you have to be aware that there are genetic polymorphisms such that 15 to 20% of Asians can actually get greater systemic exposure if they get voriconazole. So you must really watch them very carefully. So to summarize, high clinical suspicion, empirical broad spectrum therapy, timing of surgery and ancillary investigations have gone through, and you tailor therapy once fungal types and sensitivities are known. And last slide here. So despite everything that you do in that patient that I showed you earlier on, the patient ultimately passed away because he's very ill. He had metastatic neuroblastoma, severe immunosuppression, fusarium in his blood. And despite everything that we did, the disease progressed and he eventually died. And it's quite sad here. He was blind and he passed away. Thank you very much, and I hope you enjoyed the talk.
Thank you, Dr. Yuan, for your very excellent and detailed talk regarding fungal endophthalmitis. Of course, it will be very useful to help us manage these cases of fungal endophthalmitis, especially in immunocompromised patients. I think we will move on to the next speaker, and may I remind all the audience, if you have questions, please write down in the Zoom chat or our YouTube comment section. So the next speaker would be my colleague from Department of Ophthalmology, RSCM Kirana and Faculty of Medicine, Universitas Indonesia. Dr. Ari Jatikusumo is quite a senior veterinary consultant, and he underwent his fellowship at Gunma University, Japan, and from the in Singapore from the National Eye Institute in Tan Tock Seng Hospital. So Dr. Ari is also currently the Vice President of our Indonesian Ophthalmologist Association, or PERDAMI, as well as member of the Indonesian Vitreoretina Society and the Euretina. Dr. Ari will talk about treatment options for diabetic macular edema. So please, Dr. Ari, the time is yours.
Thank you, Dr. Gita, for the introduction. Very good morning to all panelists and participants. This morning, I'd like to share some of our work in retina clinics, especially in treating the most bothersome situation of the diabetic macular edema. Okay. So, okay, this is my financial disclosure, and first, I'd like to acknowledge my colleague in retina divisions, Dr. Anggun, Dr. Elviosa, and also the resident who has just completed their final test of their training, doing a small study, which along with how we in clinic, how we improve our eye care, particularly in DME management. So the DME, as all we know that as we've seen in this slide, the fundus photography is the accumulation of fluid within the central portion of the retina. It is it's a result from the failure of the blood retinal barrier, and we can categorize it as a diffuse edema where it's caused by the extensive capillary leakage, and localized edema which is caused by the focal leakage from the microaneurysma. And this DME is classified as a spared entity, and which can occur in any stage of the DRs. So nowadays, there are many anti-VEGF is the recommended treatment for DME. As we can see here, many RCT has published their outcome, and some of them with follow-up up to 3 to 5 years. And all the RCT here apparently support the superior efficacy of the anti-VEGF in managing the DME. In terms of the anatomic improvement and also the visual functions, where the latter was never been achieved with previous treatment modalities such as laser and steroid. This is from the study of Wright and Rice. It shows a benefit of ranibizumab in preventing the disease progression, which is significantly different from the control group. And from the FIFWIT and VISTA that studied the aflibercept in treating the diabetic macular edema, it shows a significant BCVA improvement compared to the sham group, and in this very superior CMT reduction are seen also in the aflibercept group. Then the other benefit of aflibercept dosing is less, so the number of injection can be reduced, which is more convenient to both the patient and the doctor. From the drcr.net protocol I show that the ranibizumab, again with the deferred laser, show a superior visual acuity improvement compared to the arm groups, which can be translated into the 10 letters gain of improvement. So we can see here that the graph. And from the protocol T, also it compared the three anti-VEGF, ranibizumab, aflibercept, and bevacizumab, all in treating DME, which show a very good restoration of the visual acuity at 2 years follow-up, and anti-VEGF associated with improvement in also in the DR severity in patients with non-proliferative diabetic retinopathy. But there's a note there that if the baseline of the visual acuity less than 20/50, it seems that the bevacizumab is less effective. So despite the positive effect of anti-VEGF injection on both visual acuity and the retinal thickening, the DME can persist in some eyes. From the protocol I, it was reported that 40% of eyes receiving monthly ranibizumab had persistent DME through 24 weeks, and 55.8% at 2 years and 40% at 3 year visits. And the VA was reported appear less favorable with times. So here, again, in a protocol T, we can see here that at month 6 after monthly injection, it's shown that almost 50% with the persistent edema in all group, but with bevacizumab group is the worst. Yeah. So Pan also has classified that the DME classification based on the central macular thickness, which is mild is if the thickness is less than 400 micron, moderate between 400 to 600, and the severe is more above the 600 micrometers. This table from protocol T from the RCR.net, if we look at all the anti-VEGF group, it showed that the bevacizumab group has the thickest central macular at the 1 year in all variables based on the BCVA and the macular thickness. And there's a report from Marasi also mentioned that the bevacizumab is less effective in central retinal thickening more than 400 micron. Regardless, but however, the bevacizumab is still suggested in initiating for the anti-VEGF treatment, regardless of the central thickness and baseline visual acuity. And he recommended that switch to aflibercept in case of poor response to bevacizumab. And we can, as we all know, that bevacizumab is I think it's the most cheapest anti-VEGF agent available and effective in case of good BCVA at the baseline. But the other agent like ranibizumab and aflibercept will do as well. But in terms of the economically, I think the two other agent is more expensive than the bevacizumab. So in our clinic, we have data that almost 40% to 50% of the DME cases is fall into the moderate and severe DME, whereas the bevacizumab monotherapy for moderate and severe DME is, if we can see previously, that there's still a persistent macular edema, And where there is still edema that we need more injection, and with the more injection, its carry risk of permanent visual loss is also higher. And I think we need some adjuvant treatment for this kind of classification, especially the moderate and severe DME. And how about the switch to other anti-VEGF agent? I think the ranibizumab is only registered here for wet AMD, and but the aflibercept is not yet registered as well. So actually both available in our country, but it's have to be from out of pocket or from a private insurance. So in the national coverage, it doesn't cover by the both of the two agents. How about the laser? Laser is somewhat beneficial in treating the DME before the era of anti-VEGF, but it can be considered for this kind of situation. But as you know, that the laser carries some other condition that is not unfavorable, like damage or permanent damage of the retinal tissue. So we try to preserve the macula as much as possible, trying not to make any damage. And we look into the other possibilities, which is could be a steroid and macular surgery. And that will be probably the option, particularly in a persistent DME. So steroid, as we already know, that it can have a efficacy of the, function as decrease the inflammation and can reduce the breakdown of the blood retinal barrier, and also have a properties of anti-angiogenic, possibly owing to the downregulation of the VEGF regulation. And may require, with the steroid, may require fewer treatment than anti-VEGF therapy. But we have to remind that the risk of steroid-induced ocular hypertension and cataract formation remain an issue. And more relevant to the treatment of the chronic DME, because the condition is speculated to be driven more by inflammatory cytokines rather than by VEGF. So steroid can be an option, and maybe consider as well as the first line treatment in selected case, such as a pseudophakic or post-vitrectomy eye, or if the patient is a high risk of thromboembolic events. We all know that there's a Ozurdex, it's a dexamethasone implant. There's a study from the use of the Befordex, the dexamethasone implant, and comparing to the bevacizumab, and the result is mentioned that there's no significant difference in the primary endpoint of proportion eyes with the 10-letter gains between the bevacizumab and dex implants group. And both agents provide a good improvement, and also can reduce the burden of injection, especially with the Ozurdex, if we compare to the bevacizumab. But unfortunately, this modality is not available in Indonesia, and it's also is not registered, so we cannot use this this modality. And there's a journal from the Dr. Fakalis using the dexamethasone. Using the dexamethasone for the slide again. Dexamethasone in form of dexamethasone sodium phosphate solution, and it is apparently a therapeutic option that might work in the persistent DME. The study by Fakalis, despite it's not particularly not for the DME, but he combined the befa and dexamethasone show comparable outcome with ranibizumab for treating neovascular AMD. And we all know that pathophysiology of wet AMD probably is rather similar to DME in terms of VEGF upregulation and inflammation. So this could be the option for our case in retina clinic. Dexamethasone and bevacizumab in wet AMD, as mentioned by Dr. Fakri, similar activity with ranibizumab in terms of resolution of the macular edema, reduction in the bevacizumab injection as well, and the visual outcome stability and improvement. And he compared as well the dexamethasone laser photocoagulation for DME is also effective improving the CMT and the visual acuity. Slide. So this study done by in our retina clinic, we use a combination BEFA and DEXA to treat the moderate and severe DME with BCVA, then OCT parameters changes as the main outcome that we are looking at. So these are those kind of the video. Yeah, because because we inject two modality here, we have to do a paracentesis before the injection, and first inject the bevacizumab, and then follow with the dexamethasone in the area of the pars plana. This is the baseline characteristic. Sorry, and probably some of the slide is still in Bahasa. And we can see here from the result that if we compare the results with other study with using the anti-VEGF monotherapy to treat DME, we can see that our result, the thickness change is somewhat more superior to decrease the central macular thickness and similar to aflibercept. So it's indicated that combination bevacizumab with dexamethasone is something we can consider, especially to DME with thickness above the 400 micron. Right, again. Okay, this is the graph show in terms of the visual acuity, it doesn't show a big difference. That probably the severe moderate DME, there has been a structural damage that affect the neurosensory cell, and the improvement in thickness only improve only in slight letters. Yeah. So this graph show that the reduction of CMT is excellent, particularly in severe DME. And we can see that the adjuvant dexamethasone agent in decreasing CMT is very useful in this kind of a situation. And this is the graph table for the adverse event. Actually, there's no serious adverse events. And so following the study, we are looking at how is safety in the term of whether any retina toxicity, and we conduct another similar study where we look at the retina function. So the results show that there is no difference in retinal sensitivity, and the monotherapy of bevacizumab and combined beva with dexamethasone in this study we can consider the procedure is safe. Yeah. So, and how about the IOPS? As we know that the injecting the two different strains, yeah, from the two different agent, which beva the volume is about 0.05 milli and dexamethasone in 1 millimeter. Surprisingly, there's no IOP spike after the injection, and the most, I think, important in this procedure is we must do the paracentesis. The last study we did is to treat those with refractory DME, which is unresponsive to anti-VEGF, laser, and steroid. So we do the vitrectomy with LM peeling, and we look at the OCT and BCF changes. And this is the baseline characteristics. It's about how the CMT is about the mean CMT is 492 micrometers with a very poor visual BCVA, and this is the video about how we do the ILM peeling during the vitrectomy. We stain the ILM, we stain the macula with ILM blue, and using the forceps, ILM forceps, we grabs and remove the ILM membrane over the macula. Okay. And yeah, after completing removing the ILM, and I continue to also give laser treatment as well, yeah, because if we can see here, there are a lot of hemorrhage and also exudate in 4 quadrants. So this is the result of our study, that it showed that there's improving in the thickness post-operative in month 1 and 3 significantly. And the central macular thickness from these graphs Also can see that the reduction is quite significant, yeah, from pre and if you compare to post-op. And about the visual acuity, there's no significant difference in their BCVA. I think it's because, again, the nature of the refractory DME has caused some permanent visual loss. And however, by doing the macular ILM peeling and reduce the thickness of the macula, we can hope stabilization of the retinopathy, and we can prevent further visual loss if we just compare, if we just observe or keeping injecting with anti-VEGF or steroid. This is an example on the pre and post OCT of the macula. We can see that after the surgery, there's a significant improvement of the macula structure. So in conclusion, the DME management is complex, requiring clinical integration of multiple factors and recognition of the chronic nature of the underlying disease process in many eyes. And DME with central macular thickness above more than 400 micrometers needs special attention before initiating a treatment. I mean, the monotherapy or combination. And dexamethasone sulfate, sodium sulfate 0.5 milligram is effective and safe to be combined with bevacizumab for severe DME. And significant CMT reduction with bevacizumab and DSP offers an alternative option when standard treatment is unavailable. And the last, I think, when the anti-VEGF fails and other modalities fails, we can consider vitrectomy with ILM peeling as an alternative option. Thank you.
Thank you, Dr. Ali, for the very comprehensive talk. I think this topic is very interesting because we do have to treat a lot of DME cases, which many times are very challenging to treat. So I think the last speaker for this session, and I think for the whole program of today, would be Dr. Anggun. Dr. Anggun Remy Yudanta. He is also my co-worker in the Vitreoretina Division of Department of Ophthalmology, RSCM Kirana, Fakultas Kedokteran Universitas Indonesia. Dr. Anggun underwent several fellowship or trainings at Gunma University and also Kinki University Medical School in Japan, followed by a pediatric retina at Changgung Hospital in Taiwan. Dr. Anggun is currently a member of the Indonesian Vitreoretina Society, or INVRS, and he will be presenting vitrectomy in vitreous opacities. So, Dr. Anggun, the podium is yours.
Yeah. Thank you, Dr. Gita, for the introduction. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everybody. Yes, thank you for the committee and National University Hospital that can make this webinar happen. So this afternoon, my talk is about the vitrectomy and vitreous opacity. Okay. Vitreous opacity is a general term for any condition that affects the structure of the vitreous. It will decreasing the vitreous clarity and will affect the visual acuity. Related issue around the vitreous opacity is about the primary and secondary causes, the symptomatic or asymptomatic, also the vitrectomy, the timing of vitrectomy. Okay, this is back to basic. Vitreous, we know the vitreous is about 80% of our eye. It's a volume about 4 cc, and consists of water and collagen fibers and hyaluronic acid. And the collagen fibers is about 15 nanometer in diameter and composed of type 2, 5, and 9 collagen. Okay, the vitreous opacity is divided into 2, primary and secondary. And primary is if associated with aging, and the secondary is associated with other ocular pathology. Can be inflammation, neoplasm, or hemorrhagic. Okay, the primary vitreous opacity is begin with the dissociation of hyaluronic acid from its association with collagen So there is alteration of hyaluronic acid and collagen. This alteration makes aggregations of collagen fibers into microscopic fibers. These fibers can scatter in the light. And the vitreous gel liquefaction, it says that being first evident the age of 4. The liquefations begin at 4 years old. This is a post-mortem study. The Oksala saw about 444 healthy eyes using USG examination. He got that before 20 years old, there is 0% of incident of degeneration. But after 60 years old, there is 80% incidence of degeneration. And we go to asymptomatic and the symptomatic vitreous opacity. First is asymptomatic primary vitreous opacity. It's very common. Tassinon et al. Have 182 volunteers. They try to see the floaters using light box and vitroscope. And the result is about 84.1% patient can see floaters when they have the vitroscope. But 80.2% patients have no discomfort. And others, about 20, have a moderate to manifest discomfort. It means that people usually have floaters, but they don't have any discomfort about the floaters. The second one is the symptomatic vitreous opacity. The main symptomatic is severe enough to make visual disturbance, and patient can have a psychological distress. Kim and Wu try to see the distress of the patient with symptomatic vitreous opacity. Kim have that the depression level is statistically significant that patient with symptomatic have a depression that than the healthy patients. The Wu also found that the symptomatic patients have a depression state is more than the patient with healthy patient. This is not a so healthy patient. This is a patient with floaters but asymptomatic. Okay, so what about the management of floaters? There are, in journals, there are 3 ways to overcome the floaters. 1 is observation. 2 is laser with NDIAC. 3 is vitrectomy, today's topic. So I'm going only talk about vitrectomy. The indication of vitrectomy related to floaters called floaterectomy. It is difficult to measure in objective way. And patients have experienced functional limitation in activities like reading small print, work with computer, or driving a car in the dark. And the vitrectomy for floaters, you know, the efficacy is not so effective in visual acuity because most of the patient comes with a good visual acuity. But in the other hand, the high numbers of satisfying patients is so high. It's about 80% to 93.5%. And how about the safety? The safety is it's said that no different with complication of vitrectomy due to macular surgery, like macular hole or epiretinal membranes. The number of retinal break is about 7 to 16%. Why? Because in the young patients, the posterior vitreous is so attached, firmly attached to the eye lamp. So when they try to make a PVD, the retinal break can occur. The second one is retinal detachment, is 5 to 10%, and cataract is 22 to 60%. This number is also almost the same with the vitrectomy and the macular surgery. And now we go to secondary vitreous opacity. There are vitreous hemorrhage, uveitis, or neoplasm. The mechanism of vitreous hemorrhage is there's an abnormal retinal vessels, like neovascularization from diabetic retinopathy or RVO or ROP, and rupture of normal vessel during PVD or trauma or retinal break, and blood from adjacent source from like macroaneurysm, tumor, or choroidal neovascularization. And the complication of vitreous hemorrhage: 1, is hemosiderosis bulbi cause of the iron toxicity. And 2 is PVR. We know that can be fibrovascular proliferation that lead to scarring and retinal detachment. And the ghost cell glaucoma and our hemolytic glaucoma, it can make the IOP go up. And now we talk about timing. Timing to have a vitrectomy, we go to diabetic patients. Early or delayed. In diabetic retinopathy vitrectomy study, the RVS 1985, they said that early vitrectomy was beneficial for patients with type 1 diabetics. It said that if we can do early vitrectomy, the visual acuity, the final visual acuity can be more than 20/40, and increase with time. 25%, 2 years follow-up, and 44%, 4 years follow-up. But this early vitrectomy, not significantly difference in type 2 diabetic between early or delayed vitrectomy. What should we consider about the timing? One is about the fellow eye, and how about the visual impairment in the affected eye, and of course the requirement for clear media to monitor progression, and about the occupational requirements. Some the patient needs binocular like a driver, and the special consideration is when there's no delay in severe VH complicated with ghost cell glaucoma. How about in RVO? RVO is the most cause of the dense VH outside the diabetic and trauma patient. The neovascular on iris and VI was reported 29% in 6 months and increased to 60% in 24 months of onset. The vitreous hemorrhage was reported in 10% of ischemic CRVO 9 months after onset. Hyra et al. Said in 10 years of follow-up patient with ischemic CRVO, there is 20% of patients with ischemic CRVO have a VH, vitreous hemorrhage. And the mechanism of vitreous hemorrhage is because of the rupture of neovascular in the retina. And there are 2 options. First is watchful waiting. 2 is early vitrectomy. When we wait if we can see the fundus. And we can, even though we can see the fundus, we still need the ultrasound. And when we have to do early vitrectomy, if there's a dense VH, dense blood, we cannot see the fundus. So the early vitrectomy will give a better visual prognosis. How about in wet AMD? Wet AMD, the mechanism is blood will come to vitreous cavity intraretinally. So it's breakthrough submacular hemorrhage. And how do we know about it is AMD or not? We have to see for the other fellow eye, the other eye. It said that 70% have a drusen in the fellow eye. And how about the prognosis? Usually it comes poor. Why? Because the blood is submaculary. And this is the indication for uveitis. There are 2 indications, vitrectomy and uveitis. One is diagnostic vitrectomy, and the second one is therapeutic. Indication of diagnostic vitrectomy is for atypical clinical presentation, non-responsive to empirical treatment, rapidly progressive disease with inconclusive, non-invasive walk-up, and strong suspicion of malignancy. And for therapeutic, the indication for vitrectomy is are medial opposites, tractional or combined retinal detachment, non-resolving cystoid macular edema, or there's an epiretinal membrane that pull the macula, and also the secreting membrane removal for the treatment of non-responding hypertony. Okay, this is I have about 5 cases. Okay, this is a male with diabetic. You can see from this ultrasound that the echoic picture, and this is the surgery. First, we do the core vitrectomy. You can see here that blood, it's so many bloods, dense blood in the vitreous cavity. And then after that, we go to the peripheral vitreous to clean up all the vitreous. You can see that the blood is in the macular area, but the other retina is still good. So we perform the laser first. We do the pan-retinal photocoagulation. And after that, we perform the LM peeling. I always use a contact lens to perform the LM peeling. And do the fluid exchange, and the surgery is finished. Second case, also diabetic patients. This severe, more severe. You can see that tractional everywhere. See, I try to, first we have to clean the vitreous, and then we try to remove the membrane using the cutter, make with the forceps also. And unfortunately, this patient, we found a retinal break. This one. This is the break. So have to clean all the vitreous, the membrane. We put air, and then we perform laser around the break. And because this is a proliferative diabetic, so we also put the laser, pan-retinal photocoagulation, and also we put silicone oil. Case number 3. This is a female. You can see from the ultrasound, it's very dense vitreous blood, very dense blood in the vitreous, and you can see there's the, sorry, you can see there's a, yes, and this is the surgery. See here, it's very dense of the vitreous opacity. I try very careful not to touch the lens. I use a very low rate of cutter. And after sometimes, finally we can see the retina under the blood. You can see that's very dense opacity. And this is how the retinas look like. This is the inferior, this is the superior. Superior is normal limit. This is the macula. We can see the exudate, there's some subretinal blood, and this is the old blood. Case number 4. Yes, we can see this is very dense, and also we can see this. Yeah, I suspected this as a choroidal. See, you can see this. It's like choroidal. And after that, this is the surgery. It's very hard to see the light inside the eyeball. Yes, you see dim light. And then I try to evaluate. And I found that there's a blood attached to the posterior capsule. So I changed the strategy. I first do the lens extraction from the superior. I perform phaco. After inserted the IOL, I started to vitrectomy and see that it's very dense. It's very hard. It's harder than the previous case. See, it's very thick. And finally, I could see the retina. And this is the retina. We can see there's a choroidal detachment over here. Choroid is folded. So the blood is come from the suprachoroidal. This is the last case. Yes, it's a male, 23 years old, have a penetrating trauma on late February, and have a repair, corneal repair. His patient, because of this injury, he couldn't walk, so he go back to his home in Mid-Java. I plan to have to do retinal surgery on this patient, but it's delayed because of the outbreak of COVID-19. And also in retina surgery on June, I plan to do the retinal surgery on June, but it's delayed because the rapid test of this patient is positive. But fortunately, the swab test, the first and the second one is negative. So I performed the vitrectomy on July 16th. This is the ultrasound. It's not so, the dent is only on the anterior part of the vitreous, but you can see there's a membrane. I changed the direction of probe, ultrasound probe, and can see this, the membrane. Okay, and this is the surgery. He had about 8 stitches in the cornea. And first I clean up the anterior vitreous and also I cut the posterior capsule. So that I go under and clean up all the vitreous. Okay, and I evaluated the fundus. See, this is the membrane right on the macula. And I tried to remove the membrane with a forceps first and continue with ILM peeling to make sure that the traction is gone. And I put silicone oil also in this patient. This is the 1 day post-op. We can see that the retina is attached. There's some blood on the optic nerve and some eyelid, some traction, but not in the macula. The macula is slightly attached. And the pre-op is, the post-op is hand movement, the 1 day post-op. Okay, thank you very much.
Thank you, Dr. Anggun, for your excellent talk and lots of videos to show us the tips and tricks in doing vitrectomy and vitreous opacities. Okay, so we invite all the speakers. We have Dr. Ari and Dr. Anggun here with me in the studio, and of course, Dr. Yuen Yosen. Dr. Yuen, are you still there?
Yep, I'm here.
Okay, because we have prepared lots of questions for you, but I will ask you some selected questions. First of all, you said that we must consider fungal etiology in endogenous endophthalmitis in immunosuppressed patients. When do you decide to do workup fungal etiology in managing the patient? And do you always wait for the response of other treatments first?
So the thing about fungus is that it's a two-part question in the sense that the first thing is the definition of what an immunosuppressed patient is. So if you have a patient who is getting chemotherapy, you're very certain that this patient is being immunosuppressed. But what usually happens is that you have patients like that patient I presented who has HIV, who has a good CD4 count. So you would think that he is immunocompetent, but in a way, despite the fact that he's got a good CD4 count, his immune system is not really a normal immune system, and he's still at risk. And then you also have, and there's actually no way of measuring how competent your immune system is. I mean, if you ask your colleagues who do lymphoma and all that, they can't actually tell you how the level of immunity the patient has just based on blood test results. So, essentially, you always have to suspect fungal endophthalmitis in any patient because of the devastating consequences that can happen because of that. With regards to when do you suspect, like I said, if you see a lesion coming from the choroid growing up, multiple yellowish creamy lesions, these are times when you start thinking about fungal endophthalmitis, and when you start thinking about whether you want to start treatment for antifungal drugs for these patients.
Okay. Second question would be, does fungal endophthalmitis still frequently occur in relatively immunocompetent individuals? And I think the second part of the question is, does fungal endophthalmitis always progress relatively slowly?
So it depends once again on, I mean, I think the immunocompetent part I've answered. So like I said, there's no way to tell your level of how immunocompetent you are just from blood tests. So you always have to suspect it, especially if the patient has risk factors. With regards to progression of the fungal endophthalmitis, it depends on what organism you're dealing with. Candida typically is slow, but the case of Fusarium, which I showed, was progressed quite fast actually. When should we stop trying to save the eyeball? I don't think we should ever stop trying to save the eyeball. The indications for evisceration will only truly be when you feel that everything has been lost, and the only way to save to prevent the disease from progressing into the orbit is to do an evisceration. Then you do that, but you will always try your best to save. But thankfully, I guess if you're very aggressive at the start, there's a fair success rate actually, I would say.
Or maybe I'd like to ask the comments from Dr. Ari or Dr. Anggun. Do you have any experience with fungal endophthalmitis here in our center?
Yeah, I think we do. Have some of the So yeah, the answer is yeah, we do. Okay, we have some refer cases from the infection divisions, yeah, and they in the beginning they have been diagnosed this case with the suspected endophthalmitis due to the fungal, and one of the cases that I remember is the response from the voriconazole intravitreal injection is very good. Yeah, I mean, but what we have to do is we have to remove to debulk of the infectious vitreous, yeah, with the vitrectomy as much as possible, and then at the end we did the injection of from voriconazole, and the clinical response is very good. And what I learned from Dr. Rina Ladis, this case, she mentioned that the more we remove the vitreous, the better the clinical response of this case, especially when we also injecting with the voriconazole. So we quite common the fungal endophthalmitis in this case.
Thank you, Dr. Ari. Maybe we will proceed to questions for you regarding treatment in DME. How is the dosing of intravitreal dexamethasone injection in DME? And which preparation do you use? Do you use regular dexamethasone, or is there any specific preparation? I think I'd like to add maybe for Dr. Yuan, here in Indonesia, we don't, I think Ozurdex is not available yet, so we only have the triamcinolone and sometimes if we have to use intravitreal dexamethasone, we use the dexamethasone for injection. Yeah, so please, Dr. Ari, maybe you can answer.
Thank you for the questions. Yeah, we use the regular dexamethasone in ampoule, and we just no need special preparation. We just draw from the ampoule and we inject about 0.1 cc of the dexamethasone, which is compared to 0.5 milligrams. And the dosing, this is a very preliminary study, so it's been never published. I mean, there's no recommendation of or evidence that there's some RCT doing the same as we do a combination bevacizumab with the dexamethasone. So actually, it's just only a preliminary study, but from what the literature that we follow from Dr. Fakalis is, he been doing the procedure for serial of injection combination bevacizumab and dexamethasone, but not in the DME case. It's only in the IMD wet AMD case. So what we can learn from the study, I think in the future, we need more study to see the efficacy of this combination. And from one-time injection of combination, it show the safety and also efficacy. I think the future we can do longer with a longer follow-up and then more injection and monthly setting. So I think it's the next step of in our division to do the procedure.
Let me ask Dr. Yuan first. Do you have any experience with using dexamethasone in the treatment for DME?
So thankfully, we're quite lucky in Singapore that we have Ozurdex, and actually we do find in cases where there is treatment resistance to anti-VEGF, that Ozurdex actually works very well. And one thing that I find at least is that if you have patients where the hard exudates are starting to creep towards the fovea, Ozurdex actually works very well in shrinking away the hard exudates. But perhaps I'd just like to add maybe two more things that I sometimes employ whenever I have a patient who is resistant. One is the use of phenofibrates. It's a drug that reduces the triglycerides, but in the field and the court studies, it's been shown that the use of phenofibrates actually reduce the severity of diabetic retinopathy. So it's actually something that I try in Singapore for cases who are not responsive. The DRCR-NET program, which is the big multi-center trials that is giving us a lot of information about diabetic retinopathy treatment now, is actually investigating the use of PEMA fibrate, which is another type of fibrate in one of their protocols. So the results should be out in the next few years, and hopefully that will show that there is some effect from fibrate use as well. Second thing that I just want to mention also is that if you look at the protocol T, patients who didn't respond at 6 months after getting 6 injections, patients who still had persistent edema and who didn't respond, if you were to keep treating them 1 year later, about half of them will have a dry macula. So sometimes you might still want to keep persisting with injections, or at least follow the protocol T protocol where they watch if there was no change and treated if there was a change. And sometimes long term you might still get a good outcome.
I'm interested in your use of your study, future study publication on phenofibrate. What is the doses of phenofibrate do you use?
So what I do is I base my practice based on the field and the court studies. So in a court it was 200 milligrams per day. A court in field it was 160 milligrams. If you're going to start phenofibrates, I would encourage you to co-manage this patient with your with the family physician or the primary care physician to make sure that they monitor for the side effects of phenofibrates. So phenofibrates are quite safe, but you have to make sure that the renal function is normal before you start. You also have to let the physicians know, because they have to monitor the patient for the LFTs, the liver function test, and the creatine kinase, because there's a risk of liver inflammation and raise in creatine kinase, which is the same risk that you get with statins. And last thing that the other thing that you'd be careful about is that when you tell the primary care physicians that you're going to start phenylfibrates, they sometimes are not very keen to start, because from their perspective, phenylfibrates is only used to reduce high triglycerides. So they would say that if the patient's triglycerides are normal, why are we starting phenylfibrates? But the effect on diabetic retinopathy in the field and accord studies was actually independent of the level of triglycerides. So we don't really understand how it works, but at least I've had some reasonably decent success with in some cases.
Yes, yes, very interesting. Maybe I'd like to ask Dr. Anggun about your experience with dexamethasone for DME.
Yeah.
Think you have a lot of experience.
Yeah, dexamethasone. We choose dexamethasone because we see that our anti-VEGF that we have with bevacizumab is not quite good for the result is not so satisfying if we have the DME with more than 400 microns. Yeah, I think in the literature, if I see that it's only about 100 to 100 decrease. So if the patient have about 600, so it still have 400. So I think that we should give another drugs so the decrease will get more. So I use combine the bevacizumab and dexamethasone, and yes, the thickness is slightly. Have a more decrease with the combination than with the bevacizumab alone. Yeah, but because the dexamethasone is very fast and go out from the eye, so I think we can give another dexamethasone in the second shot, in the second what do you call it, the loading dose. So the loading dose we can also give dexamethasone and bevacizumab. Yeah. Thank you.
And may I ask regarding the intravitreal steroids, does dexamethasone cause significant rise in intraocular pressure? Because that's one of the concerns of using steroids for intravitreal injection.
Yeah, what we get that none of our patients have increasing of the IOP. So I think and it's more predictable than the triamcinolone. Yeah.
Thank you. It's very useful information. Maybe one question more for Dr. Ari. When do you decide that pharmacologic treatment, either with anti-VEGF or steroids, is unsuccessful in treating your DME case and you proceed to surgery?
Yeah, I'm going to do the surgery in condition where the DME is still persisting, even despite after many modalities. Yeah, we use anti-VEGF, steroid as well, and also the laser. And about the injection of anti-VEGF, how many times that we can skip the injection and move to the surgery, I think if we see more than 6 months, yeah, and 6 months, if after monthly injection there's no improvement, I'm considered to switch to other modalities or doing the surgery. The surgery, I think, particularly I will do for the very severe case and in the last eye. So I think in the last eye we have to be more prudent to be before proceed to the surgery, because yeah, we have to educate the patient as well. Injecting, keep injecting all the time is doesn't without risk actually. Yeah, there's a risk of endophthalmitis and other condition. So there's the advantage of the surgery is hopefully we can, as we mentioned, also many publication that with surgery, most of the cases will have a stabilization of the retinopathy. So there's another aspect of it before we proceed to surgery, but the long term of how the patient will cope with this.
Okay. How about you, Dr. Yuan? Do you often do vitrectomy to treat DLA cases, especially the persistent cases where pharmacologic treatment is unsuccessful?
So I'm actually quite junior in terms of my vitreoretinal surgery career, but generally in my center, I guess the indications from our end would be if there was a very thick epiretinal membrane or if there was obvious vitreomacular traction on the macula itself. But I guess on our end, we rarely have to go all the way towards surgery. I guess thankfully, once again, because we have Ozurdex, and that kind of helps us quite a lot. We also, I mean, usually we also switch around between the 3 intravitreal injections to try and get a better response. So if patient doesn't respond to Avastin, we try Lucentis. That fails, we try Eylea. And then towards the end of the year, we're getting a new drug, Brolucizumab, which hopefully will be a lot stronger as well. So I guess from our end, the indication, the need to go towards surgery for persistent diabetic macular edema isn't really that high, thankfully.
Thank you, Dr. Yuan. And I think there are questions for Dr. Anggun. How long do we wait to declare that vitreous hemorrhage case is non-clearing? And how do you decide to perform or to postpone vitrectomy?
Yes, thank you. I think it depends on the case, yeah. But like diabetic, if this patient has no history of laser or get any treatment, I think we should go faster. Yes, maybe within 1 month, means the patient come to our clinic. So, but in the RV or AMD, maybe we can still wait. Yes, but if the dense blood, I think it will not absorb in 2 or 3 months. Yeah, so I think if we cannot evaluate the fundus, so I think 1 month is the maximal time for waiting.
Maybe. Yes, when do you decide to do a vitrectomy in uveitis? Should we wait for maximum results from non-surgical treatment first?
Okay, thank you. In our clinic, the uveitis is managed by our colleague in the inflammation division. So usually there are some cases that got that. One is for diagnostic. They already tried many regimen, many measurement, but there's no other improvement. So they asked to have a diagnostic vitreous, so perform the vitrectomy. And for the vitrectomy for therapeutic, I think I have to see about the macular condition also. If the because of the epiretinal membrane and the distortion of the the distortion of the patient's side. So yes, I will perform the vitrectomy with remove the epiretinal membrane and also perform the ILM peeling. Yes, but one thing that in the uveitis patient usually it's so sticky posterior vitreous. Yes, it's so difficult, so challenging. Sometimes we make a retinal break also. Yeah. So yes, that's the challenging case. If we perform the epiretinal peeling and also the ILM peeling in the uveitis patients. Thank you.
Okay. So do we still need? Do we still have time for further questions? Okay, we do have. So I think there's also a question. I think for all, Dr. Ari, Dr. Yuan, and Dr. Anggun as well. I think this is very characteristic in tertiary care hospitals in our part of the world. There's lots of long waiting lists. So sometimes the surgery the planned surgery cannot be done as scheduled. Is there any therapy you suggest to give in these patients? Maybe monthly or periodic monitoring, or maybe giving pharmacological drugs such as NSAIDs or anything, or maybe anti-VEGF treatment or others, what would you suggest? Maybe start with Dr. Ari, Dr. Ari, and then Dr. Anggun.
Is it in terms of the vitreous opacity or heavy minutes or something?
For the, I think in any case with vitreous opacity.
So I think vitreous opacity by itself, usually when we see in the clinic, it's not active bleeding. I think usually it's already clotting. And what we expect is by defer or delay the surgery because of the curing time. I myself never give anything, any special medication, but I just advise the patient to be seen clearly to my resident to be to check the IOP and to check as other condition, because oftentimes we can vitreous hemorrhage with delay treatment, it can lead to adipoclastic glaucoma. So actually I have no particular treatment pharmacology for this case.
How about Dr. Anggun?
I think we have the same management. we don't give any medication for the dense vitreous hemorrhage. Just follow up with ultrasound examination, and if 1 month there's no any improvement, so we go to vitrectomy.
And maybe lastly, how about you, Dr. Yuan? Do you still experience many delayed treatment for these cases, and the patient has to wait in line, and you have to do certain treatment?
So I guess from my end, the waiting time isn't really that bad, but we do have cases where patients don't want treatment, don't want surgery. So I guess in that perspective, I can answer. I agree with my colleagues that we shouldn't give intravitreal anti-VEGF, especially if you're not planning for surgery, because there's a chance that you may make it may cause induced traction once the vessels regress. One thing I do watch out for, especially for chronic VH patients who don't want surgery, is sometimes the VH can spill into the anterior chamber and you get almost like a ghost cell kind of glaucoma. So if patients who can't, so maybe one thing I might add is that if the patients have a chronic VH, then they can't get surgery earlier, you still want to watch them closely in the anterior chamber, start a bit of steroids, topical steroids to reduce the ghost cell glaucoma, because they can develop secondary glaucoma if that's not controlled, and that can be bad for them. But beyond that, I agree. The best thing is just to get them to surgery as soon as possible.
Thank you. I think we all agree on that. Yeah. So I think that is all the time we have. Once again, thank you to all the speakers for the very enlightening talks today, from session 1 to session 2. And I think once again a big round of applause for all.
Thank you. I'm clapping in Singapore too.
Selamat siang, sampai jumpa. Bye.
Good to see you.
Yes, so this ends my job as a moderator. So I give back the mic to Dr. Sari Wulandari. Thank you all for being with us. Thank you. Bye-bye.
Thank you, Dokter. Thank you, Dokter Gitalisa. Yang terhormat kepada seluruh peserta webinar, demikianlah acara ilmiah RSCM Kirana-NUH Collaborative Webinar Series pada hari ini. Terima kasih untuk seluruh peserta yang telah berpartisipasi dan kepada seluruh pengisi acara serta panitia yang mendukung acara ini. Thank you very much, Dr. Yuan Yusen and Dr. Dawanan Kaan for the interesting lectures. Also, thank you for all attendees from National University Hospital. Terima kasih pula kami ucapkan kepada para sponsor PT Chandra Pharmaceutical, PT ZEIS, dan PT Afina Sinar Cemerlang yang telah mendukung perjalanannya acara hari ini. Semoga kegiatan hari ini bermanfaat bagi kita semua. Sekaligus, kami sampaikan bahwa Perdami akan mengadakan Perdami Virtual Scientific Meeting pada tanggal 18 September 2020. Sehingga kami mengundang kepada seluruh teman sejawat untuk dapat berpartisipasi dalam acara tersebut. Seri keempat dari webinar series selanjutnya akan diadakan pada hari Minggu tanggal 26 Juli 2020 dimulai pada pukul 9 pagi waktu Indonesia Barat. Registrasi dapat dilakukan melalui tautan yang akan kami sebarkan di media sosial, baik grup chat maupun Instagram @RSCM Kirana. Demikian saya tutup acara webinar siang ini. Selamat siang. Wassalamualaikum warahmatullahi wabarakatuh.